All right, welcome, ladies and gentlemen. It's my pleasure to open the third day of Research Week. I need to get with the program. Firstly, we acknowledge the Kaurna people are the traditional custodians of the Adelaide Plains and pay respects to elders past, present and future. I would like to make a special welcome for the students of Hamilton Secondary College. I hope you enjoy the afternoon. There'll be some entertaining presentations, we hope. So, very good. Good to see you. It's my pleasure now to welcome... Oh, by the way, there's a very large audience in here. It's good to see, Grant. You've filled the room. But they're out there in the ether. There's another 100 people at least, we hope, from various places. Grant I first met when I came to Flinders in 1986. So 1986 was my last year of surgical training, came here to complete the fellowship and then never left. Grant was gastroenterology registrar and then he left. But he ultimately settled in Victoria, in Ballarat, and established a gastroenterology practice, but he then developed other interests in healthcare improvement, and I think he refers to himself as I better just refer to the exact words here, Grant. The quality, I did have it. Activist, quality activist, that's right, that's the word I was looking for. But he has very energetically pursued that around the nation, and I guess we're about to hear with how much success. He's also has his own consulting business, consulting in assisting organisations with their governance, quality and safety agendas, and has taught a quality improvement program in association with Bernie Harrison from the Institute of Clinical Excellence in New South Wales. Grant also spent 2 years at the Royal Adelaide Hospital in Carlin as a leader in clinical governance. I suppose it's the easiest thing to say. So he has had quite a bit of experience in South Australia in recent times. So Grant, we're very keen to hear what you have to say. Welcome.
Rob, thank you. Oh, hello. That's not what we're looking for. How do we do this? Thank you, Tanya. Look, thank you, Rob, for inviting me to speak at this meeting. It's great to see so many people here, and can I too acknowledge the traditional owners, the Kaurna people, and express my thanks to them for welcoming me back onto this land where I grew up. Welcome to you guys too. I spent 25 years living in Western Victoria and very familiar with Hamilton. You've produced some pretty darn good footballers over the journey, and I look forward to seeing some of you guys roaming around a footy field in future. This will be a pretty simple talk, so no excuses, you'll be fine. I want to talk a bit about organisations, and as Rob suggested, I've had the very real privilege of working at every level of the healthcare system, from being a really busy, overly hands-on clinician to working for and with ministers as they've tried to understand how best to provide resources into the community to achieve the greatest good for that community. And I've had some pretty interesting jobs in between, including working at the shiny new big hospital down the end of West Terrace for 2 years, which was just extraordinary. Let's crack on. This is quite some time ago. I'd have to say I first walked into this lecture theatre nearly 45 years ago, and it's bringing back all sorts of horrible feelings and horrible memories. But this is a bunch of young physician trainees around a bit earlier than the time you arrived, Rob, and you'll recognise some of these people. I would like to point out, though, the very early adoption of a career in quality. We're not wearing a tie, which I'm not seeing any ties in here. That's very good. You'll see bare below the elbows, and you'll see the ultimate quality improvement or the long white socks, which I think we need more of in today's society, if I'm honest. Before I start, I just want to acknowledge that this is a really difficult time in healthcare. I think we're in the most troublesome space that I've ever seen our healthcare systems in this country, and it's not just COVID. We're in a time, I think, of genuine crisis, some of it related to workforce, some of it related to the way we structure and govern our health system. And I'm spending more and more of my time now thinking about and working in that governance space, and I am concerned about it. I also do want to acknowledge that the caring workforce, all of you, have really struggled over the last couple of years as we've been in this pandemic crisis, and I do acknowledge that. I'm no longer at the clinical coalface, and I'm grateful for that. But on behalf of the community, I do want to thank you for all the work you do to keep our community safe in these difficult times. Let's just agree with these statements. I'm not going to present any evidence to support them. I just want us to agree with this because it's relevant to the subsequent talk, but it's also relevant to the whole safety and quality agenda, which is premised on a couple of things. We don't run a health system in this country, in my mind. We run an ill health system. If we were serious about a genuine health system, we'd put much more emphasis on the social determinants of health, a roof over our heads, a job, and education and so forth. But because of this sort of democratic environment that we live in and work in, we tend to focus on an ill health, the ill health side of the system, which is why we're seeing a very interesting proposition in this morning's paper to spend $3 billion on one hospital, which I find extraordinary. But let's also agree that care is still not safe enough, it costs too much, it's not reliable enough, it's still largely, if we're honest, built around people like us, rather than being truly built around the needs of the consumer in our community. And just for the sake of the record, I just do need to say that our record in Indigenous health in this country still is terrible. So let's think about organisations. Organisations are in effect the unit entity which delivers healthcare. In a country like Australia, every bit of healthcare that we deliver happens in an organisational context, whether it's a big ugly hospital like this or a little clinic on a corner. Organisations have lives of their own, they have cultures of their own, they have ways of thinking about what they do. And in Australia, organisations exist within a broader healthcare context, which largely reflects the fact that we're a Western democracy. We elect governments to provide, through our tax system, resources to achieve a greater good. And a health system is part of that greater good. And governments really don't have many tools. They can fund things, they can regulate things, they can create policy for things. Using those tools, individual entities called organisations then take those policy, regulation, funding models and through our clinical microsystems or clinical teams deliver services to our patients and communities. So our organisations have a societal context. Wherever you look around the world where healthcare has failed, there is always an organisational component to that. Sometimes it's individual clinicians going rogue, but the vast majority of times when care fails, it's because of systems of governance, leadership and management. And in part because of that, we've established what I'll call a safety and quality industry. And I use that term somewhat pejoratively because I think we have created an industry which doesn't necessarily help us. 1920, the US College of Surgeons built what it called a set of minimum standards that it thought hospitals should adhere to. In the 1950s, the US Joint Commission built the first accreditation model for hospitals on which all accreditation models around the world have subsequently been adapted. In the 1980s, in response to some really major concerns about safety and quality in the US system, the Boston-based Institute for Healthcare Improvement was established. Big private think tank in a way that only the Americans can do, but it's had a very significant influence on the way we think about healthcare safety and quality subsequently. Intermountain Healthcare, which I'm going to come back to, was starting to become concerned about its own quality issues and started some early quality improvement studies, which they have then taken and developed further, and I'll show you something about that shortly. The International Society for Quality in Healthcare was established in the late 80s with significant Australian input, and Australia does have a long and proud track record of involvement in the safety and quality agenda. In 1995, the Quality in Australian Healthcare study was published, and it's still the most cited article that the Medical Journal of Australia has ever had. It was written by our colleague Bill Runciman with Bernie Harrison's input, and in essence what they did was looked at hospital admissions across Australia and across New South Wales, and South Australia, and found in summary that 16% of people being admitted to hospital had some sort of adverse event. Of those people who had an adverse event, 0.7% died as a result of their care. And it's one of those, I remember where I was when I saw that, moments for me, and it helped to profoundly change my way of thinking about my role as a professional. Off the back of that, governments around Australia responded by building the Australian Council on Safety and Quality in Healthcare, led initially by Bruce Barraclough, a Sydney surgeon, and subsequently became the Commission on Safety and Quality, led by our colleague Chris Baggerley. Around that time, all of the states and territories were starting to build their own infrastructure. And in 2013, for the first time ever in this country, it became compulsory for hospitals to be formally accredited against a set of minimum standards. Some of this stuff's pretty old, some of this stuff's pretty recent. Implicit in the idea that organisations are important in quality is this language that we call clinical governance. And the clinical governance language came out of a major episode of organisational failure in the UK back in the 90s at Bristol Royal Infirmary, where they were caring for children, neonates, who needed cardiac surgery. And without putting too fine a point on it, their care was terrible and they were basically killing these poor children. Major review in the NHS, major review of medical professionalism in the UK led to this new language called clinical governance. This is the original definition of clinical governance, and to my mind, it's still the very best definition. It puts the emphasis on systems, on organisations, on accountability for three things: for continuously improving their care, for ensuring that we meet the standards that are expected of us, and from a leadership standpoint, creating an environment, or in my language, a culture, in which excellence in clinical care can flourish. And that last phrase, I think, is enormously important, and I think it should be our mantra as it relates to the delivery of services in organisations like this. Before I go any further, I should have said right at the start that this is a bit of a Coles to Newcastle conversation, because I regard this organisation as being right at the forefront of quality improvement work in this country. You're doing what I've not seen any other organisation do at the sort of scale you're doing it. You've really moved a long way down this path of creating a culture in which excellence of care can flourish, and I do want to acknowledge that and thank you for that. Within this idea of clinical governance, in my mind, it creates a specific role for us as clinicians. This idea of leadership of clinicians, or leadership by clinicians. Our task is, as clinicians, to deliver excellent outcomes. Not because it's the right thing to do, but it's actually a core part of our professional identity. A lot of work's been done on medical professionalism in particular in the last 20 years, and I've had the privilege of being involved in some of that from a College of Physicians standpoint. And we've been very clear in that work to say that good enough is not good enough. It's your professional responsibility to ensure that care is genuinely excellent. Underpinning all of this is this idea about leadership. The leadership literature is long and extensive, and people create careers out of talking about leadership, but in simple terms, it's my view that leadership exists for one purpose and one purpose only. It's a set of behaviours that's about driving change. Leadership has no other purpose than to drive change. So if we think about clinical leadership, it's about driving change within the care systems that we have responsibility for. So let's think about organisations. Here's a simple definition of an organisation. It's a company or other group of people that works together for a particular purpose. Nice, simple definition from the Cambridge Dictionary, but there's several elements to it, and there's some deep complexity in this. Firstly, it's about people. Companies are people businesses. They're not robot businesses. It's about humans. Secondly, we're doing something together. Companies are not about isolated tribes or isolated individuals doing their own thing. It's about doing something genuinely together. And the most important part of this is around purpose. What's the purpose of a healthcare organisation? I ask this question a lot when I'm running workshops on this, and you get an extraordinary range of answers. And I dare say if I did the same now, and I won't for time reasons, I'd get the same sort of answers out of this group, because it's not necessarily something we consider. Here's my view. The purpose of organisations is about the why. Why do we get out of bed to come to work? Why do we go to the trouble and expense and hassle and challenge of building big organisations like this if we're not really clear about what they're for? Ultimately, every organisation is about delivering economic value to the organisation's owners by meeting the needs of customers. The fact that this is a public hospital doesn't change that view at all. The owners of this building, the owners of this service, are the community, the Australian community, not just the South Australian community, the community that receives services from it, the community whose taxes pay for this. Not unreasonably, as taxpayers, we should actually expect some sort of economic return from an organisation like this. The economic return is about the value of the care that's provided. From a staffing point of view, though, purpose really matters because we want to get out of bed in the morning knowing that the work we do is important. We want to feel valued for the work we do. We want to feel that we can draw a line between me getting out of bed and some sort of benefit to those we serve. And it creates a really interesting role for leaders and managers. And I should have said before, this is a talk largely for leaders and managers, but I hope you'll all get something out of it. Leaders and managers are tasked with this idea about running the organisation in a way that our staff, our people, can do work that they're proud of. There's no other purpose, in a sense, of a leadership system or a management system in any organisation than to create an environment in which excellence will flourish. And I'd put it to you that if excellence is flourishing, we're much more likely to be proud of the work we do. How do we know what organisations are for? We can go back to source documents like legislation in your case, or a constitution in the case of some other organisations, or we can look at the public statements that organisations make about themselves. And every organisation in the world has got some sort of mission and vision statement. It's sitting on a wall somewhere, generally down near the main offices where only the executives can see them. But nonetheless, we have these things. They're often on websites too, to be fair. Here's what yours says. Thriving community, reliable and respectful healthcare. There's not much, not a criticism, but there's not much in there about excellence. I find that interesting. Here's one that does refer to excellence, and you notice where it's from. World-class care, world-class research. Interesting. This is Royal Melbourne, leading the way on improving quality of life. Interestingly enough, drawing a sense of purpose around individuals' purpose, quality of life. I find that quite interesting. Because I spent an awful lot of time in Melbourne. Here's the Alfred just down the road from Royal Melbourne. Leading healthcare for the people of Melbourne and Victoria. What's leading healthcare? I don't know, but it sounds good. And this one I find really interesting. This is Calvary, a big private operator with a footprint across Australia. Quality, compassionate healthcare to the most vulnerable, including those reaching the end of their life. They're basically a big for-profit private sector operator. The vulnerable part, the palliative care part that they do very well, is a small part of their work. I find that really interesting. This is an interesting paper from the US which looked at vision and mission statements in American hospitals and said, what difference do they make to organisational performance? And not surprisingly, when you look at the evidence, it's pretty marginal. So I think we need something that's a little clearer, a little more coherent, a little more able to be easily grasped, particularly by our staff, but also our community and those we serve. Here's what I think our purpose is. The purpose of healthcare organisations is the production of great care, what you do, what our clinicians do with their patients and their consumers together through a co-production model in a way that ensures that care is great, is my sense of what our purpose of any healthcare organisation should be. The role then for leadership, remember leadership is about change, the role then is to ensure that care is enabled. We do the things that create the culture in which excellence can flourish. Doing the right things. The role for management, which is a much more transactional set of activities, doing things right, is to ensure that care is properly supported. So that's how I conceptualise the purpose of this organisation and any other healthcare organisation. If we're not focusing on great care, we've somehow got our purpose wrong. So it's my view that our governance and management models really must reflect that very simple view. And every organisation I've really looked at, there's been some sort of dissonance between that sense of clinical purpose, consumer-focused purpose, and what our organisation is actually saying. 2014, I wrote this paper with a colleague where we tried to answer, tried to answer the question, why has the safety and quality movement been slow to improve care? And this was in response to a previous paper where some Australian clinicians had basically thrown up their hands and said this whole safety and quality industry thing we've built is just not working. It's not really helping our consumers. And you know what? They were kind of right. So we tried to understand that, and we talked to some of these elements down here on the right, including poor culture, trust, lack of transparency and so forth. But underpinning this all was this idea that as organisations, we're really much more focused on what I'll call regulation and compliance rather than genuine improvement. In other words, we weren't focusing our organisations on what really mattered, on the purpose of our organisations, the core business of providing great care. Rob alluded to my 2 years at Carlin, which is the most extraordinary work I've ever done in quite a long career now. in 2016, I was asked to come and take a look at it with some colleagues because they'd had some very major safety and quality problems which had impacted directly on patients at that organisation. They also impacted on patients here because it was related to concerns about chemotherapy in patients with haematological malignancies. And we spent the better part of 2 months on the ground looking at the organisation, and this is in the pre-new hospital days, to be fair. But the long and short of this very large and quite expensive body of work was that this is an organisation that wasn't focusing on its core business. You can read this report, it's publicly available, so I'm really happy to show it to you. But in essence, we found an organisation that was far too focused on regulation and compliance and not enough on improvement. And I subsequently had 2 really interesting years there trying to shift it towards improvement. That was all going very well until Corda Mentha appeared on the scene, and I shall say no more and move on to the next slide. So how do we move beyond this? Well, here's what we currently do. You know, we kind of apply the same level of thinking to the current set of problems that actually got us into trouble in the first place. I think we've got to be smarter than that. This is a framework I use all the time in my consulting work, and in my consulting work, I'm often part of a team. We go into organisations and we look at their preparedness for their accreditation piece, their capability around their clinical governance model. This is McKinsey doing a very big piece of work looking at businesses around the world, thousands and thousands of businesses. And based on their performance, they were able to categorise them into ailing, able and elite. And then asked what are the attributes of these organisations. And to cut a long story short, elite organisations have a very clear sense of purpose which permeates their organisation. Their culture is deeply steeped in their organisational purpose. Google's a great example. Apple's another great example. Everyone who works for those firms knows what they're there for. The leadership model is about change. Their leadership model is about encouraging and enabling a culture which says we can be better. They're very clear about the capabilities that they need to make the organisation hum along. And they're really exercised by the idea that they want to engage their staff in getting out of bed in the morning to do really good work that they can be proud of that's connected to purpose. And importantly, elite organisations are learning organisations. They make a very deliberate attempt to learn to be better. And I think for us to get to that, we need a change in organisational mindset. Our healthcare organisations are largely still asking, are we good enough? Are we meeting the standards that are set for us? Are we complying with the requirements that government set for us? I don't like working in organisations like that. I'd much rather work in organisations that are adopting this second approach. How good can we be? What's the limit? How far can we push this so that we're really delivering a great organisation that's delivering great care? This is the best example I know. This is John F. Kennedy in 1962 saying to the American people, by the end of this decade, we're going to put a person on the moon. 7 years. Extraordinary when you think about it. Not because it's easy, but because it's hard. So making a deliberate choice to do something really tough. And here's the kicker, because it's going to benefit everybody. And those of us who are old enough to remember the moon landing, and Rob, I know you can, and I can, Andrew, you can too. I'm sure we'd all agree that, in fact, he's right. That program did benefit mankind. It had some downsides, unquestionably, but it has benefited mankind. So this is asking how good can we be? Sky's the limit, if you like. I think if we're going to get to this, we've got to expand the role of clinicians and consumers in pushing our organisations into that space. The chairman of Sony in 1987 had it absolutely right, that when he said a company will get nowhere if all of the thinking is left to management. You don't improve any organisation by pushing it from the top down. It's got to be from the bottom up, in effect. Cleveland Clinic, which is one of the great American healthcare organisations from a quality improvement standpoint, puts it this way. Our task as an organisation, our task as staff, is this idea of a relentless collaboration on improvement. We're going to improve our care, we're going to improve our organisation. So I put it to you that from an organisation standpoint, being elite is actually a deliberate choice. You can choose to be elite, you can choose to be failing. This is why in my work in governance and senior management, we talk about this, and we talk about the very deliberate choice to engage your staff in a much better understanding about what the organisation's really here for. Here are a couple of examples. This is Virginia Mason, a big healthcare network based in Seattle. Some of you will have heard about it. The quality team should know it well. They transformed about 25 years ago around one simple idea, that they wanted a better patient experience. They took some time to get to this, but ultimately they transformed their organisation by adopting the Toyota car production system in its entirety throughout every level of the hospital. Trained all their staff, built the language, built the processes, and for many years they've now been regarded as one of the elite organisations in the US. This is Salt Lake City, where I had the privilege of spending some sabbatical time to learn about quality improvement. And Salt Lake City is the home of the Mormon Church, and the Mormon Church own Intermountain Healthcare, which is their healthcare system. Big, ugly tertiary quaternary hospitals right down to small primary care across a number of states in the southwest of the US. They had some real problems with safety and quality back in the 80s, and they realised that they needed to make it better, and so they transformed around an idea of continuous improvement. Taking Deming, an engineer's view that a bad system will beat a good person every time. And what we really need to do is build much better systems so that our really good people, our really clever people, can be effective all the time. And Deming and his PDSA cycle are well known to many in this room. And so Intermountain Healthcare have become one of the global focal points for learning about how to do continuous improvement at scale. And I'm so glad I had the opportunity to spend some sabbatical time with them and to meet Brent James, who really is the father of this work in healthcare globally. If we're going to do this, we've actually got to have a way of understanding what quality is. It's one thing to say we deliver great quality care, and every organisation I go to, by the way, says we deliver great quality care. When you ask them what that means, most are not able to tell you. This is the Institute of Healthcare Improvement's triple aim approach, and to my mind, this describes great quality care. It's great quality care if it improves the health of the people we treat, if it improves their experience of care by being designed and produced with them. And they don't shy away from the idea that better care is cheaper care. And I use that word cheaper quite deliberately because we said at the start, and we agreed at the start, that we spend too much on healthcare. These domains of quality match up really well with the Institute of Medicine's quality domains, which, Rob, I think you're using here in your quality reporting, as many organisations are. So I think this is a way of thinking about excellence. I think it's also a way of thinking about purpose. This is an organisational purpose to deliver care of this quality. I actually think it's also a professional role. As a clinical professional, as a management professional, I should be aspiring to this sort of care. So I use the language better, safer and cheaper as a shorthand way of describing this care. And as I say, I don't shy away from using the word cheaper. As a taxpayer, I want us to have cheaper care in this country. But I also want us to be working in an environment where staff are experiencing the fourth part of the triple aim, this idea that the Americans coined of what they call joy at work. And I'm yet to find a better terminology, but they recognise that if staff are engaged, are happy to get out of bed, are feeling proud of the work they do, care will be better. They also recognise that this is a virtuous cycle because when we're delivering better care, we all feel better about being at work. And there's an increasing push globally to work with staff on this idea of joy at work. I'll call it engagement. Organisations which are failing inevitably have a common theme of staff being separated or removed from what you might regard as being the overall purpose of the organisation. So it's incumbent on managers and leaders in organisations, I think, to be really focusing on staff. And as I said at the start, this is a problem right now. Our care is at risk. Here's a bit of work that we did with one organisation where we took that triple aim approach and said, what does it mean for your organisation? And they came up with this idea of right care. Better, safer, cheaper, excellent care is right care if it's delivered in the right place by the right team with the right skill set to the right person for the right reasons at the right time at the right cost for the right outcomes. This is how one organisation chose to interpret this, and they then started to measure their care against these various domains. So quality improvement at scale, I'd argue, is everyone's business, all of us, that's why you're here. But it's ultimately a management responsibility to make it happen if we're going to do it at scale. Ara Darzi, who's a famous London-based surgeon who subsequently became health minister in the UK for a while, put it this way: you can't mandate high-quality care. You can't stand in the CEO's office or in the front of a theatre like this and demand high-quality care. You've actually got to have a management system in place which allows the talents of your frontline staff, who are unbelievably clever. Healthcare is full of the cleverest people in the world. Requires their talents to be unlocked. But here's a problem. We're putting people into organisations that are kind of the antithesis of that, and many of our hospitals and healthcare organisations really don't get it right. And so what you end up with is frustrated, disengaged and burnt out staff. And I'd put it to you that many of the organisations I've seen from a consulting standpoint have had elements of that in place. We don't actually teach people quality improvement, and I do think it's to your eternal credit that that's very much on the radar here at Flinders. This is an interesting paper from New Zealand where they looked at undergraduate programs in medicine, nursing, etc., and asked, are we teaching people quality improvement? And what they found is what we'd find if we did this study in Australia, which is that we're great at teaching professionalism or compliance, but we don't teach quality improvement. There's an old and I think really tired argument about a lack of space in the curriculum, but being really practical, and Rob, I think you'd probably agree with this too, that we don't necessarily have the skill set sitting in our faculty, in our universities, to teach some of these really basic skills to people in our undergraduate programs. A couple of other problems as clinicians, and I'll put on a clinician hat now, we tend to use tools that suit our need rather than really drive genuine improvement. And this is a Cochrane review of clinical audit, which suggested that there's a tiny chance of getting some improvement if you do clinical audit as one of your primary tools. Clinical audit's great if you then tie it into an improvement piece that responds to the areas of concern you've identified, but most of it don't do that way. We tend to do audit, we park it, we drag it out for an accreditation visit, we put it back in the drawer, and then we move on to the next problem. Audit's largely about demonstrating that we're meeting the minimum standards that are required of us. What about morbidity and mortality? Largely for the doctors in the room, but also for others. Some really good work from Guy Madden and the College of Surgeons, suggesting that morbidity and mortality meetings, which are very much part of our professional life and professional ethos, are really good from an educational standpoint. Important quality assurance role. They can identify areas where additional work is needed, but in and of themselves, they're not much chop at driving improvement. So if your overarching clinical culture is around using these sort of tools, then there's work to do. So back to Darcy and unlocking talents, we've really got to, I think, talk about systems. And I use this quote constantly in my work. Systems really are perfectly designed to achieve the results they deliver. So from a leadership standpoint, if you don't like the results you're getting, you've got to think about the systems you've got in place. And we've known about this for 170 years. This is Florence Nightingale's seminal work from the Crimean War in 1850, where she standardised sanitation and hygiene and was able to reduce the mortality of those wounded in war spectacularly. 170 years later, we're still arguing about how you go about improving care. Remarkable. Here's some work that we did some years ago when I was in Ballarat. We had a problem with VTE prophylaxis in medical inpatients, and we did the usual banging heads together and trying to educate our staff to be better. We accepted that they were really clever, but they could actually be better if we just educated them some more. And every organisation does that. I know you do it too, because every organisation does. And not surprisingly, that made squat difference. So we then changed the process, and we changed what was then the National Inpatient Medication Chart to really force people to think about VTE prophylaxis and to think about appropriate prescription. And that made a significant difference to the outcome, which was sustained over 12 months by doing nothing. We'd changed the process, we'd sustained the benefit. Small example, here's a bigger example. This is the NUCA system of care from South Central Foundation in Alaska, which looks after the interests of the Indigenous community there. The community leaders were really concerned about the quality of care that their people were seeing, and so they changed their systems of care, based it in what had meaning to them, their stories, their cultural values. And I referred at the start to our challenges around Indigenous health. I think we can learn a lot from this. And over a 5-year period, they significantly improved use of services, significantly improved care, and significantly improved patient satisfaction and staff satisfaction. They changed the process of care. Here's Bristol. Remember, Bristol was the organisation in the UK that was, not to put too fine a point on it, killing babies. The red line is their mortality. And when they finally realised they needed to do something, they did move some people on, but they also significantly changed their processes of care. And over a short period of time, they were able to reduce their mortality in these most needy, most vulnerable babies down to a level that was consistent with the rest of the country, the green line. It can be done. This is the only bit of data I'm going to show you from Intermountain Healthcare, who really have led the way on this. And this is some of their first work in one of their hospitals around deep post-operative wound infections. And they realised at the time, we're talking 40 years ago now, mid-80s, that their antibiotic prophylaxis rate was poor. And so they did a lot of work to change the process whereby antibiotics were delivered preoperatively, so that over a few years, they're basically up to 100%. And you can see what happened to the number of infections over time, a dramatic reduction. And most importantly, and I am going to point at it, this number here, the amount of money they saved by avoiding harm. There's no doubt in my mind now that there is no argument that quality care is cheaper care. What's really interesting, though, is that the US national standard in 1991, the right-hand column, the US at that time was quite happy to accept 2 to 4% of their patients experiencing a deep post-op wound infection. Intermountain Healthcare said, no, we want to be much, much better than that, and they were. They've continued this work over the last 40 years, and they now save 2% of their budget annually from their quality improvement work. That's a remarkable figure. They have chosen quite deliberately to be elite. They have chosen quite deliberately to be better than the standard that applies to them. Being elite is a choice. We're going to redesign, we're going to have to redesign around our customers. We must put our patients first. I'm not going to go into the data on this, but you all know it. We get care properly organised, properly built, properly delivered with our customers, our patients, our clients. We get better outcomes, better care outcomes, better organisational outcomes. What makes a patient-centred organisation? Some nice work from Karen Luxford in Sydney, basically suggesting that if we get those attributes of elite organisations in place, we're a patient-centred organisation. There's lots of reasons for us to choose to be elite. How many people do you need to change before organisations change? This is some nice work again from McKinsey's, which looked at lots of businesses and said, how many people do you need to get truly engaged in the purpose of this business and its transformation before the organisation shifts? Cut a long story short, once you get to 7% of your staff properly engaged in that idea or with the skills to drive that idea, your chances of transforming the organisation double. It is in your interest as a manager and a leader to make sure that your staff can do this. Let's do a quick business case. A great skill for clinicians to have, by the way. If you've never done a business case, go and learn how to do it. They make a real difference. Let's pretend you're an organisation with an annual turnover of about 1.5 billion. You've got 10,000 staff, and it costs about 5,000 a person to train them in quality improvement, the sort of model that Rob and the team are doing here. Let's suppose you train 700 staff, so you're getting to that 7% tipping point. It's going to cost you $3.5 million. And then let's suppose you're as good as Intermountain Healthcare and you can save 2% of your budget annually. That's a return on investment that you'd happily accept from the share market or the housing market or from any other form of investment. It's compelling stuff. So here's a message. The finance folks are the most important members of your improvement team. A couple of reasons, because money is part of the quality definition, if you believe me that better, safer and cheaper is how we should think about care. And secondly, because finance guys and girls by and large have much better access to the big offices in organisations like this than we do. Because CEOs and boards in particular will be having to respond sometimes in a much more immediate and substantial way around finances than they will around quality of care. It's one of the interesting dilemmas about healthcare. Here's a bit of work we did at an organisation which had a problem with length of stay, just again to prove the money matters thing. Their length of stay was way too high, and so we did a body of work which said, listen, if you reduce your length of stay down to the average for your benchmarking group, not to the bottom, just down to the average for your benchmark group, we'll save about $30 million. But more importantly, we'll actually give you an additional 43 beds that we've freed up. And by the way, you've got a major problem with ramping of about 40 patients a day. Here's how you solve your ramping problem. Here's how you solve your money problem. By changing the process of care that is contributing to your long length of stay. It's not rocket science. So if you're a healthcare manager, how do we do this? I won't dwell on this but there's plenty of evidence about how this is done. Bottom 2 points I think are the most important. Let team members lead and train your team to improve their healthcare. In summary, managers, and I've been a manager so I get it, it's not easy, but I think what we need to do is apply some evidence-based management. We expect our clinicians to apply evidence-based medicine. I think it's not unreasonable that we expect our managers to apply evidence-based management. Here's some data from Canada where they looked at their organisations that were genuinely high performing. I'm not going to go through this, just the top 3. Focusing on quality as your purpose. Purpose really matters. Focusing on system improvement as your core strategy. Give people the skills to drive system improvement. Develop leadership skills. You don't get change without leadership. Leadership exists to drive change and has no other reason. And build better governance, and I absolutely agree with number 3. So let's go back to Deming. Remember, Intermountain Healthcare built their model around Deming, who was the leader of this whole process improvement thing, coming out of an engineering background. And he described 14 principles for improvement, and he was very deliberate about saying these are principles for management. Not for clinicians, not for the workers in a factory, these are principles for management. Let's look at some highlights. Constancy of purpose, improve every process, train on the job, leadership's crucial. Get rid of fear. How often do we hear organisations in healthcare saying that fear is one of the dominant cultural elements? Lots of nodding of head. I've seen that in every organisation I've looked at. Break down barriers. And the last one's probably the most important. Put everybody to work on the task. Line everybody up with your purpose and put them on the job. It's worth noting that some things can't be improved. Brent James, who taught me everything I know about quality improvement, would say that 9 out of 10 improvement projects should fail. Not will fail, but should fail. Because if you're doing enough of this work, you're going to have some that won't work. But importantly, from those 9 out of 10 that do fail, you've got great organisational learning. And don't ever underestimate that. For the sake of the exercise, that's my golf handicap over the last year. And as much as I've tried to improve it, and there is some random variation, as you can see there, it doesn't work. I'm stuck at about 7 and I can't make it any better. For those of us not in management positions, I think we can do some things. We can understand our organisation, understand how and why decisions are made. There is a management process, respect that, work with it. Again, when I've looked at failing organisations, the management process has either been poor or people are choosing quite deliberately to go around that. Be a leader yourself. I think this sense of personal leadership is enormously important in healthcare. The management system really does matter, and as I said before, use the finance guys and girls. They are your best friends when it comes to any project. If you can demonstrate a financial benefit from a project, you can almost guarantee executive approval of that. And purpose, patients first always. It goes without saying in a healthcare organisation populated by clever professionals that this is the case, but I think too often, to be honest, we lose sight of it. What happens when we get it right? What you'll find is organisations will have these 4 elements. An agreed and robust quality improvement method, a way of making care better, a skilled faculty to assist, people who know what they're doing, who can be of real help to people on the coalface who are trying to make it better. Leadership and management are actually actively bought into the idea that things can be better and support that, and a deep understanding that teams matter. And we know this is what good organisations look like, because this is what your organisation looks like. This is straight from the paper that Rob and Peter Hibbert wrote some years ago about this place and how you've succeeded in driving improvement at scale. And again, I want to congratulate you for doing that work. You're leading this country, in my view, on doing this at scale. So here's my mantra: better has no limits. How good can we be? Short answer, as good as you want to be. You can choose to be elite as an organisation. You can choose to be ordinary. Either way is okay, but I'd put it to you, if you're wearing a management hat, you're much more likely to get staff engagement. You're much more likely to get better care if you choose to be great. With that, I'll stop. This is where I live in Ocean Grove, Bowen Heads, a place very familiar to Dr. Padbury and his golf clubs. But this is my version of better has no limit. This is God's own country, and this is a place where you can have a fantastic semi-retirement. So again, I thank you for inviting me back, Rob. It's great to see the work you're doing, and I congratulate you all for that. Thank you.
Thanks very much.
Grant. I think the ocean's where I should put my golf club. All right. Well, you want me to hold this thing? So, are there any questions on the... Sorry? Are there any questions from the floor? Who's courageous enough in this no-blame environment? Yes. Okay.
You talk about moving from a culture of compliance to a culture of being elite. Inevitably, in any organisation, there's some staff who have no interest in being elite. How do we encourage all staff across the entire organisation to make that choice to try and be elite at whatever it is they do?
It's a very, very good question. And I think some of you who are heavily involved in the improvement work here would admit that it's not necessarily been taken up across the entire organisation. I'd have to say that's pretty common. I think if you're a clinician, though, and I will focus on clinicians rather than others, it's unarguable that your primary purpose is the delivery of great care. And I think for those of us who are clinicians, that then allows leaders in the organisation to have a really meaningful conversation about what great care looks like. No clinician gets out of bed in the morning to deliver poor care. But I think where you've got evidence that care is not good enough, which is different to poor, you can actually then start to have organisational conversations about how good can it be? How good can we be? I did some work in an organisation that had a problem with a neurosurgical set of cases. They had people staying in hospital for 7 or 8 days for something that should have been a simple day case. And in that group of neurosurgeons and neurosurgical nurses, there were believers that it could be better and a group who said it can't be better. And over time, what they did, though, was come together around a shared purpose that this is what good looks like. And they did a really nice improvement piece that shifted all of those 200 cases a year to day case. Job done. They've proven that care can be better. What's the next thing we move on to? So I think it's about the story we tell, it's about the narrative we build around it, but it's also for clinicians at least around our primary professional purpose of making care as good as it can be. Managers and leaders, those who are not at the clinical coalface, I haven't met one person in a CEO's office yet that's fought against the idea that clinicians should be enabled to deliver better care. That's their purpose too. This is not a them and us thing. Managers and leaders in organisations are joined in the same purpose. It's just that most of us don't actually know how to have the conversation about it because we haven't actually got a way of thinking about what good care looks like.
I can remember some years ago doing a talk similar to the one Grant's just done, and one of the audience at the end put their hand up and said, "Look, I'm a sort of a half glass full person, near enough's good enough." Where do I go with that?
How good can we be?
But framing it in terms of not satisfying the CEO, it's not about the organisation, it's actually about the population you serve. And framing it in that, there are all these things focus back to that one, and that was Grant's theme, to that one thing. And if you can get people to focus on that, a lot follows. Andrew.
Look, thanks very much, Grant. Really enjoyed it. It was inspiring. I got stuck early on when you took us to the paper by Bill Runciman and his colleagues. So as you know, Bill was an intensive care specialist here, and then moved across town and did that piece of work and continued to do that for a long time. I think this was the piece you told us there, 16% of patients had complications and of those...
Adverse events. Yeah, the quality in Australian healthcare setting.
Big paper. For me, it was an interesting story of lost opportunity because my colleagues and I and lots of other people didn't want to listen.
Yeah.
And it took a long time to do that. So can you help us understand what was going on and then how, because sometimes you can't see things until you're ready to see them, is my view. So help us understand that and maturity of thinking in organisations. It's
a great point, Andrew. I presented that paper at a journal club to a bunch of physicians, and you and I were talking about physicians before. They're much harder to deal with than surgeons, who you can easily corral, as Rob's successfully done. And I presented that paper, and it was, I presented the background to it, and the background briefly is that a similar study had been done in the US, and Bill and Bernie Runciman and Ross Wilson and others decided to repeat it in the Australian context. So it was in essence a proof of concept study. Does the same thing exist in Australia? And lo and behold, it does. And I should say it's also been repeated in many other countries around the world with comparable systems, and the data stacks up. Somewhere between 10 and 16% of people in a hospital will experience an adverse event, some will die. When I presented to a bunch of physicians, it sank like a stone because we don't want to believe it. We don't want to acknowledge that our care is sometimes problematic. We don't want to acknowledge that our systems of care are not as good as they should be. And I think some of that's about professional pride. And for me, the task here is to move away from this idea of individual professionalism to individual professionals, as Deming said, working in a great system. And so I think we're all joined in this task of building the best systems we can so that individuals can feel like their work has made them proud, to come back to that first language. It is about organisational maturity. I think it's also about organisational leadership, the top of the organisation chart saying, we're going to be elite. We're going to support you and enable you to deliver the best care you can within the resources we've got available. But that's our task. And that takes time. You guys have been working on this here for, 20 years, Rob? Give or take a bit? I'm aware of other organisations around the country where this has been a 30-year journey, and sometimes it's really hard. But you don't get it without the commitment of clinicians, working from the bottom up, if you like, and from people at the top of the organisational chart saying, this is what we must do, for this is our purpose. And it's that purpose piece that I think is often profoundly missing for all of us. We all want to get out of bed to do a good job.
Any other questions or comments?
Just one question.
Nadia.
I can probably shout.
You can shout into the microphone.
Obviously, we got here at Sullen a really good culture of continuous improvement, and I think from Angie and Rob, we're up to about 8% of staff are trained.
Yeah.
How do we sustain it going forward? Are we reliant on the individuals leading it at the moment, or how do you keep it going?
Why would you stop training? Why wouldn't you keep going? You may well be at that tipping point if you believe McKinsey's 7% data, but why would you stop? You're already doing great stuff. I know that you've transformed significant aspects of what you do. Keep going. For this to really work, it has to become a bit like the chairman of Sony said. It has to become the business of everybody at every level of the organisation. And I think personally you're well on the way to that. I'm much more impressed by what you're doing here in terms of scale than in virtually any other organisation I've seen in this country, where, to be honest, what we do is give people a label called Quality Improvement Team, and there's some here, and we park them in a corner and they only appear at accreditation time. That's mad. This stuff has to be deeply embedded in your normal care processes. So I expect to see quality improvement people in and around care delivery. Keep going. Don't stop.
Hi.
Question about this or about footy or?
Would you be able to use this concept this model to improve a different sector such as education?
Absolutely. Yeah, absolutely. I think that the McKinsey framework I showed you talks about organisations across a range of spaces, and many of those were from the traditional business sector, but also from education and from elsewhere. If you're not clear about your purpose as an organisation, in my mind, you've got no hope of being better. You've got no hope of engaging your staff, who are your most important asset, in a meaningful conversation about what good looks like, let alone how you actually get to that. So, yeah, one of the great joys of my life is that I studied business, and I deliberately chose not to study healthcare management because I thought that's a kind of short ticket to go nowhere with my career, Grant. So I studied business generally, and I think for me it was enormously important, and I've taken lots of ideas from the broader business sector into the way I think about healthcare organisations, and you've seen some of that today. I think there's much to learn from healthcare, but healthcare needs to learn much from other sectors, including education, where the focus of really good schools on their student as customer, I think, is something we need to be much more understanding of in healthcare. So thank you. Great question.
is I think you could go to the headmaster and say, we need to adopt Deming's principles
Absolutely.
of improvement in healthcare.
Yeah.
Deming, it was industry that it started and it's been adapted for healthcare. So very, very excellent question,
it is a
wonderful
great question.
observation. I'm glad that that was one, excellent.
Yeah, thank you.
Anybody else wish to have a go? Simon Windsor's trying to shut me up. He held up the 1 minute thing. It's sort of like
Come on, Rob,
runner
we've
at the
got
football
3 minutes
match where
left,
he
I think.
holds up the 30 seconds left. And I reminded him that it was not until 2 o'clock. So there are a few minutes, if you wish. All right. You've got your way, Simon. Was there someone else? No? Okay. Well, perhaps we'll explore this in the last, we've got from 4 till 5 o'clock, and I've written down a lot of things here that I think we can explore. One of them, though, I think, was just the last bit, governance, clinical governance. It's amazing. I think that definition you put up really resonates because it allows aspiration, or it promotes aspiration to excellence.
Yeah.
And I think clinical governance is far too often seen as a restrictive, authoritarian thing where everyone's in a straitjacket and it's following a process. I really like that, and I think that's perhaps something we can draw out later. All right, thanks very much, Grant. That was a very thought-provoking, clearly a large amount of experience and knowledge put into that presentation. Congratulations, and we look forward to your contributions during the afternoon.
Thank you.
Thank you.
Hello, everybody. Welcome to this afternoon's panel, free paper presentations. I'm Angie Goodrich. I'm the Director of the Continuous Improvement Unit. And firstly, I'd like to acknowledge the land we meet on today, the traditional lands of the Kaurna people, and I wish to pay my respects to elders past, present and future. And I just want to say, actually, for any of you that were at the opening session with Ray Mahoney, that was such a really great session to hear around the importance of relationships before partnerships and the importance of co-design. So I really encourage you to get along and have a look at that session if you haven't seen it. So we had a lot of amazing poster submissions for this session, and the panel found it really, really hard, and the quality of all of the submissions were amazing. And so we have also invited other poster presentations to submit some of their work, and we do have an improvement gallery out in the foyer for you to have a look at. So there is a bit of a competition, and so the Flinders Foundation have kindly are going to award $2,000 to the winner of this session. And on the Hoover app, via the app, you are able to vote on your favourite poster presentation. So I invite you to all do that at the end of the session. Now, presenters will have 10 minutes to present their projects, and then what we're going to do is have a bit of a joint Q&A session at the very end. So we will reserve questions to the very end, if that's okay. So it's with great pleasure that I invite Emma Lesk up to the podium. Emma is going to present her poster of Introduction of a Collaborative Patient Assessment Model in a Virtual Care Setting. So come on down, Emma. Thank you. And we have Darren as well.
Is this mine?
Can we use that one?
Awesome. Thank you so much. So my name's Darren Duff. I'm working in the Virtual Care Centre. I'd like to start by just acknowledging that we live, work and play on Kaurna lands, and really thank the group, the committee, selection committee, for the opportunity to talk here today. We're going to talk fairly quick because we have a lot to say, and everything we do down in virtual care is done at double time. So bear with us as we kick through. So the Virtual Care Centre opened back in December 2021, providing virtual emergency care, really looking to support patient referrals from SA Ambulance, our regional clinicians, residential aged care facilities, and more recently supporting SAPOL watch houses in delivering care to people who they have in custody. At the moment, when we put our poster in, it was more than 7,000. We've just kicked over 8,000 patients that have received a virtual consultation through our virtual emergency service. And at the moment, we're sitting at about 70% of our patients are managing to avoid attending an emergency department. So in our current state, so when we first opened, we had a current state, and essentially what we'd done is replicated a bricks and mortar emergency department, where we had a very linear process that wasn't actually as efficient as it could be. So we had an average call length there of 43 minutes and a wait time of 6.5 minutes. We actually thought we could do a little bit better than that. So the other thing that we identified as part of our problem is that we had a significant workload imbalance. So the doctor was setting the pace of the care, and we had nursing staff actually waiting for the doctors to finish their consultation before they could actually get on and do their bit. So we'd kind of been watching the individual cases. We also watched the overall system at work in the virtual care service to sort of just understand how could we actually adjust things to do things a little bit better. The underutilisation of the care coordinator was one of these things, and what we found was the doctors were actually doing stuff that the care coordinators could and should be doing, but they didn't feel like they had permission to give that work away, which is a little bit bonkers, but it's just what we saw. So we thought we needed to solve that because doctors are way more expensive than nurses, and we needed to use our resources better. In virtual care service, we kind of use a core learning pathway where we talk about having our concept, understanding what is the question that we want to answer, clearly identifying a value proposition for the patient, for our service, and for the system more broadly. We're looking at our approach and how we might attack any of the problems that we find. In terms of design, we're looking at a co-design project or having some workflow systems and getting the people that are involved in the system and the care involved in that workflow redesign. In terms of our experience phase, we look at testing our design, we do daily observations, and we look to gather those insights and learnings and adjust as we can. And then we go into our learning phase where we analyse our outcomes and impact, we provide some evaluation, and then we look to implement and embed the learnings that we've had into the way that we deliver care. So I'm going to hand over to Emma, who's going to talk a little bit about the particular project we delivered.
Thanks, Darren. So as part of our concept phase, we asked the question, could we rearrange the work within existing resources to reduce the workload imbalance and deliver a better outcome by reducing our call length? So our approach was a workshop to design and then using our PDCA experiment template to trial. So a value proposition for the patient was faster access to the appropriate service and plan of care. For the service was improved efficiency with increased utilisation of the care coordinator and more meaningful work for the medical officer and care coordinators. And releasing capacity into the system by being able to release the ambulance crew earlier and improved service efficiency for us, being able to take more referrals. So as part of our design phase, we held a value stream improvement and design thinking workshop where we had 16 multidisciplinary team members of nursing, admin, leadership, medical staff and SA ambulance staff. So we used value stream analysis to understand our current state, using data from our direct observational tracking of 70 calls as our baseline. We had swim lane maps and Yamazumi charts to understand our current state. We used design thinking methodology to brainstorm ideas for future state and to propose a new workflow, ensuring the value for the patient remained at the centre. So as part of this, with the two groups, we had 2 different workflows proposed and we decided to trial one of the workflows. So our method was to trial 30 calls and to track the key metrics of the call time, the work time for each role and the staff feedback. So you can see there just our 2 different groups that we had, 2 different approaches. Top group sort of did a lot of simulation and role play and the bottom group was a bit more methodical in our approach. So our design was that a patient would be referred to the SAVCS, that undertake a triage process, they'd then see a clerical staff member for registration in EMR, and then the medical officer and care coordinator would provide a joint simultaneous patient assessment. So the benefits of this was it was using our experienced clinical nurses, it was a team approach for review, and there was one less handoff which reduced duplication of information and potentials for error. So in our experience phase, so the actual doing the do and testing the experiment, it occurred over 69 days. So we tested the experiment under selected conditions when staff from the workshop were present and under appropriate service conditions, meaning that we tested 1 call using this workflow every 1 to 2 days. As we progressed with the experiment, we realised that we weren't going to achieve our target at this rate, so we opened the experiment up to all staff within the service. So as a result of that, we tracked 33 calls involving 60% of the medical officers and 83% of the nursing team. So just those photos there. So just the top photo is the Care Coordination Centre. So we're based at Tonsley. So we've got one of our nursing staff and one of our doctors providing a joint consultation. And then just that bottom image is what the doctor sees on the computer screen. So we've got Pamela there acting as our patient. She's our program director. And for the patient, they see a similar view, except the larger image for them will be the doctor, and it's rotated with the doctor up the top. So in our learning phase, our outcomes were we reduced our call length by a median of 16 minutes, which was a 37% reduction. We reduced our wait time by a median of 4.5 minutes, which was a 69% reduction. And based on this, this could increase our service capacity by approximately 9 calls per day. So that's based on a 3-doctor roster per day. So we've just got our value stream map down there, down the bottom for the trial. So you can see we've got the medical officer and the care coordinator joint together at the end of the call. So also as part of our learning phase, we identified that we had a more even work balance with a decrease in the medical officer time on the call and an increase in the care coordinator work. What we observed was that the doctor was starting to leave the calls earlier to be able to start their documentation while the care coordinator remained on the call and organised the plan of care for the patient. So we've just got the work balance chart there, so you can see we had a slight reduction in the doctor time on call, but a significant increase in the care coordinator involvement. So for our staff experience in the learning phase, it was really positive. So we had 93% of the medical officers and 82% of the care coordinators indicating that the care coordinator added value during the assessment and care planning. It was interesting to see that the medical officers felt that the care coordinator added more value than the care coordinator thought that they did. So even when the nursing care coordinator was performing tasks that they didn't see as adding value, the doctors really felt that that was adding value to the patient assessment. So the key themes from the feedback were that we had reduced duplication of handovers, a quicker process for referral of the patient to out-of-hospital services, nurse-to-nurse discussions when the patient was referred to us directly from a residential aged care facility, so for the nurse in the aged care facility to have that collegial support. Knowledge sharing for the medical officer and care coordinator, and we found that it was really beneficial when the nurse joined the call when the doctor was working from home. So we do offer that as a model of care. So as part of our next steps, we wanted to observe the system impact. So we'd done our experiment under selected conditions. So we wanted to know what would happen if we ran this workflow for every single call that came through the service. So we watched the system over 2 full days of service operation from 8 a.m. in the morning until 10 o'clock at night. So we watched 34 calls, and we found, so just on the graph on the left there, so from our trial to our normal operating conditions, we did find that there was a slight increase in the total call length by about 5.5 minutes, but we were actually, from tracking each of the tasks at each of the roles, able to attribute that back to the fact that we had increased the tasks of the triage staff member to upload the ECG at the time of triage, which was a really value-adding step for the medical officers. And then we can see just on the right-hand side there on our work balance chart, we've continued to decrease the doctor workload and continued to increase the care coordinator workload, which was what we were wanting to see. So based on those observations under the normal operating conditions, we adopted the collaborative-based workflow as part of our standard practice. And for continuous improvement, what we wanted to do was review the tasks that the care coordinator was actually performing on the calls. So we observed that as part of our system workflow, and then we held a team-based problem-solving session to identify different opportunities to trial to enhance the way that we deliver our service to ensure the right work is performed by the right person. So what we identified was that 20% of the tasks that the nursing care coordinator was performing could be performed by clerical. So I've just got a photo there of one of our clinical nurses running a problem-solving session. So some of the outcomes of that were that they could redesign the seating layout, have a care coordinator and clerical buddy system, have earlier communication from the medical officer to the care coordinator for distribution of tasks, and standardise the clerical tasks. So as part of our project work group, we'll continue to monitor the workflow. We've got a commitment to 2 days per month of system and continuous observations, and that's been done by improvement coaches and also by the nursing staff, and we'll feed any improvements back via our learning system. That's all. Thank you.
Thank you. Fantastic start. A great example of reducing waste to increase capacity and reduce waste by underutilised resources. So well done. All right, so handing over now to Anita Lim. Anita is going to talk about the re-engineering the cardiology ward round to improve efficiency of care. Welcome, Anita. Thank you.
That one, thank you. You can hear me? Yep. Oh, where's the clicker? Thank you. Like you, I want to deliver the best possible care to my patients. That means excellent care. But I'm being held back. Our patient care in the cardiac care unit is not excellent at the moment. Cardiac nurses are so busy dealing with hospital demands and providing direct patient care that we no longer have as many opportunities to discuss our patient needs with the medical staff on ward round. nor do we get to be involved in decision making as much as we used to. Patients are deteriorating and there are concerns about our infarct mortality rates. So in my PhD, I'm trying to build excellence by creating a workplace culture where doctors and nurses can get together and work together and consider the patient's choices in the care that they want to receive. Look at this picture. There is someone missing from the ward round. Where is the nurse? The nurse is not in the room. Now, a nurse is there to advocate for the patient's needs and to be involved in the decisions made about their care so that the patient actually understands their treatment plan and they actually receive quality care. But we have many problems with our ward round and delays in the delivery of patient care. Are we actually making effective decisions? Unfortunately, we've lost a lot of our experienced nurses over the last couple of years. This calibre of experience in our nurses is very difficult to replace. It takes time, energy, and a lot of education at the bedside, which we are lacking. The senior nurses cannot get to the bedside because they are so busy running the ward. We rely on a lot of relieving and junior nurses to provide patient care to our cardiac patients in our acute unit, and we really appreciate them being there. Sometimes there are only 2 CCU nurses on a shift who can support those nurses and help them become familiar with things they don't know about, like cardiac monitors. They're too scared to take the patients off the cardiac monitor to have a shower, and they're too scared to let them get out of bed. Did you know it takes so long for a decision to be made about recommencing a cardiac medication that we have to wake our patients up at midnight to give them their pills? They tend to fast for long periods, awaiting procedures, because they are often cancelled due to emergencies, or sometimes they're not even booked. And on the day of discharge, it's very common that they want the patient to go home, but they still haven't been out of bed. So I want to make sure that our patients receive the right care at the right time. So in this study, I made some structural changes to the 3 cardiac stream ward rounds. These are our 3 cardiac streams. Now, I work with a great bunch of doctors and nurses, and we all want the best possible care for our patients. But even though we try, we just don't seem to be getting together enough. And cardiac streaming has definite proven benefits, but an experienced nurse does not belong to any cardiac stream. They have up to 4 doctors with 3 in the arrhythmia team. Ward rounds are often simultaneous or they're ad hoc, meaning they come and go. And there is 1 nurse coordinator available to attend all 3 ward rounds, and that nurse cannot be in 3 places at once. Our nurses need to be there to maintain quality, because nurses drive quality. You can see that in the wards during the accreditation process, and as the hospital as a whole. Ultimately, overall in my PhD, I'm trying to create excellence so that we can improve our quality indicators. So in my ward round study, I want to improve patient participation and improve workplace culture through situational awareness so that everyone has a say and we aren't just listening to the most senior doctor's advice. The more we communicate and collaborate, the more we understand and learn from each other. We need leadership that will also help this culture to form trusting and respectful relationships. This culture also needs to be sustained. We acknowledge the contribution of nurse surveillance that we can then empower nurses to make effective decisions. So a system that supports nurse decision making leads to proactive care, which you can see over here on the right-hand side, rather than the increasing reactive care that we seem to be giving during the weekdays, especially on a Monday when we have to get 10 to 12 patients admitted to our unit and 20 beds are full. This is when the nurse coordinator is stuck at the cardiac monitors and at the phones, trying to get those patients in and discussing staffing and bed management issues with the nurse unit manager and the bed manager. It seems more important at that stage to focus on access to the beds rather than prioritising the care of the patients that are actually in the beds. So I want to get the coordinator back on the ward round. So this is my design. I designed the ward round based on what I found in the literature and looked at the elements that lead to an effective decision. So the cardiac nurse is there to help the patient, to help advocate for them and help them with their voice. I gave the doctors and nurses time and space at the beginning, the middle and after the ward round to get together and collaborate and communicate. I relied on the cardiologists and the registrars to be the senior members to help maintain this culture. I asked them to start later to help us prepare for the ward round, see all the CCU patients instead of coming and going, and to also come back at the end of the day to update overnight treatment plans. Not as a set of instructions, but another opportunity to discuss with the after-hours team through situational awareness about what we need to do for patients that might deteriorate that night. I also gave them a pro forma and a checklist to help keep things on track. Now, I followed the RMO's rotation through the 3 cardiac streams. Each RMO spends 4 weeks with each cardiac stream. So the first 2 weeks were control and the second 2 weeks were the intervention. And we did this 3 times. I was basically trying to switch culture on and off and to see if there was a difference. Now, no other ward round studies in the literature have actually measured my primary and my secondary endpoints, except for IDC insertions. And my results showed that instead of waking those patients up, most of them would get their pills before they went to sleep at night if we were trying to give them their catch-up dose. This reduction in the medication delays was statistically significant, but really significant for the heart failure group. And I wonder if that's because I asked the heart failure nurses, who are really well specialised and had a great relationship with their doctors, I asked them to go on the ward round during those intervention days. So structural ward round changes for a small pilot study did work for my primary endpoint. And although not statistically significant, patients did tend to fast less because procedures were booked earlier. They had less bed rest and they had more patient education. Over here on the right, those green bars show me that the intervention gave my patients a bit more information about their driving instructions and their cardiac rehab folders. And I did do a patient survey. At the end of the first ward round, I asked all the patients some questions. That was about 24 to 48 hours after being admitted. And I asked them how well they understood the aspects of care that were discussed in the ward round. And for a short 12-week study, again, the green lines do outshine the control line. So I was pleased to see the patients did tend to understand a bit more. I asked them about their satisfaction rating and it was a very high one for both control and intervention. They were just grateful for the care we gave them. But even though they did not necessarily understand their treatment plan, they did feel strongly about being included in the decisions made about their care. So in summary, the components of my build include improving the patient voice and literacy by adding a nurse to the ward round, empowering nurses to make effective decisions, and providing a teamwork culture that supports situational awareness. But now that we know this, do we accept things as they are, or do we use this information and take the opportunity to change our culture and use the tools we have at our fingertips to improve care delivery and create excellence? If we can deliver excellence, then we must sustain it. We need our leadership to help us do that. Therefore, patients will be happier because they will receive the right care at the right time. And they may understand their treatment plans. Doctors and nurses might then belong to a culture that supports communication and collaboration. They may have a better understanding of patient needs and their treatment plans. Effective decisions could improve quality care delivery, which could ultimately make the staff happier. They might stay. All of these elements may create and sustain an overall happier and less stressful environment, and the cardiac care unit could be on its way to having a reputation as a centre of excellence. Thank you. Thank you to my supervisors, and this is just on the left, you can see that's where my pilot study fits in my PhD. Thank you.
Great, wonderful. Thank you very much, Anita. Lovely to hear about the importance of team coordination and the impact that that has on the patient. All right, handing over now to Brianna Reid, who's going to talk about the increased utilisation of the Marion Priority Care Centre. Thanks, Brianna.
This one?
Which one do you want?
I don't care. Thanks, Angie. Thank you, everyone. It's my privilege today to be talking to you about how we applied Salen's 8-step problem-solving methodology to increase utilisation at the Marion Priority Care Centre. So in March 2020, a priority care centre was established at the Marion Domain Medical Centre, and this had already changed locations after being located at the Hackham Medical Centre and had some issues down there. So we tried a little bit closer to Flinders, and that move happened in March 2020. So the Marion Priority Care Centre is a joint initiative between Salen and Wellbeing SA that allows patients with minor injuries and minor illnesses to be redirected and seen by an emergency doctor and nurse outside of the emergency department. The Marion Priority Care Centre has a 3-way governance, with Wellbeing SA providing funding and oversight of the program, Helios, which is the private GP provider who manages the environment and provides the medical officers, and Salen, who provides the nursing staff and I'm going to say the patients as well. So within the Marion Domain, there is access to radiology, pharmacy and pathology services. But in November 2020, I was requested by the Salen COO to commence an improvement project as the Marion Priority Care Centre was only seeing on average 1.7 patients per day and had a 16% decline rate for patients that were referred there. And this was inadequate for 3 reasons. We were performing much below other priority care centres across the state. It's a very expensive model when you have a full-time doctor and nurse to only be seeing that fewer patients. And most importantly, it wasn't achieving the desired effect, which was to divert patients away from the emergency departments so that they had the capacity to see much more acute patients. So clearly we had a problem worth solving. So Salen, actually, I think it was you, Mr. Morris, had provided us a target that 70 patients should be seen at the Marion Priority Care Centre per week. So we created ourselves a target that by March 2021, the Marion Priority Care Centre would accept at least 10 referrals per day, and that the first-time quality of patients getting accepted by the Marion Priority Care Centre would be greater than 90%. So we had our work cut out for us. That was to increase patients by 8.3 per day and to increase our acceptance rate by 6%. A long way to go. So what did we do? We really unpicked the data to identify, was there any patterns to the referrals by day of week, by time of the day? Who were the key users of our service? And we had a lot of stakeholders in this service, referrals from SA Ambulance, SAPOL, obviously the emergency departments, the Women's and Children's Hospital. What were the reasons why we weren't accepting these patients, why we had to decline such a large % of these patients? So we did direct observations of the priority care centre processes, and I did sit there an awful lot during that period of time, and also direct observations within the emergency department triage space here at Flinders. We held a session with all those key stakeholders that I talked about to work through the process from identification of a suitable patient to what happens to patients once they have been seen or treated at the priority care centre. We then held a brainstorming session to identify all the reasons why patients weren't referred or accepted to the priority care centre, and that allowed us to identify some key root causes. Those root causes. The emergency department had no incentive to send patients to the priority care centre. The triage nurses didn't have the knowledge around what the priority care centre capabilities were or what appropriate patients could be sent down there. And when the emergency department was busy, it was the least of their thinking to actually refer onwards. They were more concerned about that next patient in the triage queue that might be a cardiac, chest pain. They had no idea what was coming up. The second root cause was the hours of operation and service do not align with the emergency department demands. The current inclusion criteria was too restrictive for a higher referral rate, and inadequate direct admission pathways to avoid referral onto the emergency departments. So there was some work happening around direct admission pathways, so we really tried to focus on those sort of first three root causes. So the first one about emergency departments having no incentive to send patients to the priority care centre. It was a little bit political because there was a general feeling that the same patients that were suitable for the priority care centre were the patients that were also seen by our nurse practitioners. So, you know, we were getting rid of some of their business. So there was a reluctance to give these patients up and on refer when we started to sort of really ask the questions why. But in order to address this, we increased rotation of our emergency department nurses through the priority care centre, which included the nurse practitioners, and that helped to start to build relationships between the two departments. It increased the knowledge of the type of patients that were suitable to be sent down there, and it also provided knowledge of the services that could be provided for those patients. We tightened up workflows. We created really streamlined orientation processes because this is a nurse and doctor that's just rocking up on the day potentially with no other support to ask questions, etc. And we need to make sure that we had really clear communication processes to ensure that we created that reliability and consistency for patients that are coming down to the priority care centre. We also employed out-of-hospital nurses and they were introduced within the emergency department to identify and refer suitable patients, which really took the pressure off of those triage nurses who were more concerned with the patients in the queue and making sure that they were safe. The second one was around the hours of operation and services not aligning with the emergency departments. So we created, sorry, I just realised I missed one, didn't I? That phone, I bet you're all wondering what that phone is. So we actually installed a direct phone line from the emergency department waiting room to the priority care centre with clear instructions of the types of conditions that the priority care centre could see, so that when patients were sitting and potentially waiting hours within our emergency department, they actually had that patient choice on whether they would like to try and find care elsewhere that could provide a similar level of assessment. And so that's just a picture there of the phone that was installed. And it does take a bit of work to get a phone installed. I don't know if anyone's actually had to do that before, no? All right, the second root cause was the hours of operation and services not aligning with the emergency department. So when we did our brainstorming and process mapping, two of the big concerns was around the fact that pathology services closed at 5 and radiology closed at 5. And so that was a big reason why after 5, emergency departments and SAS didn't want to send patients there because they didn't feel like they'd get that same level of care. So we created an urgent blood pathway, which was established with SA Pathology, which is Salen's pathology provider, for outside the domain provider's operating hour, that bloods could be couriered and actually results could be delivered in a much tighter time frame than what they would even get from having bloods done with the domain provider. And also created a radiology pathway for a bit of an assessment to look for suitable patients that could be assessed by a clinician at the PCC after hours, and then have scheduling of that radiology for the patient to return next morning, have their imaging done, and then be seen directly by the doctor. And then the current inclusion criteria is too restrictive for higher referral rates. So we sorry, I'm losing my page here, developed a clear minor injury pathway that could be promoted. And the reason that we went with minor injury over minor illness is there's a lot of variability around minor illness and grey zones between what consists of a minor injury versus a illness instead of a significant illness. So where it was a lot clearer around, you know, what a minor injury is and one that you'd need to actually attend an emergency department. We got agreement that it does not need to be a clinician referral for minor injuries, so we were able to promote the service and contact details more broadly within local schools, kindergartens, childcare centres and sporting clubs. We increased the available equipment in order to decrease those declines. So we purchased electric wheelchairs so we could accept patients with more significant mobility issues. We acquired a slit lamp so that eye injuries could be safely examined. And when I say we acquired, our lovely biomedical department found 3 broken slit lamps that were ready for the bin, and were able to actually compile parts from each of those to create one solid slit lamp. So we also, you know, reduce waste. So we were able to actually increase the scope of the patients that we were seeing at the Priority Care Centre. So as you can see, after doing the diagnostics and by putting targeted interventions in place, the number of patients attending the PCC quickly increased. And by April 2021, and we were a month late, I do apologise, we were consistently seeing a median of 12.3 patients per day with an acceptance rate of 95%. So does anybody know what happens when you start to hit a target? You know it, they doubled the target. And that's what happened, exactly what happened in June 2021. But with continued Plan, Do, Study, Act cycles, the numbers have continued to rise, and as this graph shows, which is a much more recent graph, the Marion PCC is now consistently reaching the revised target of 140 patients per week. Each week, an average of 28 patients are being referred directly from a SAL and emergency department, and 13 ambulance patients are being rerouted instead of presenting to our ramp. So, this is a great example of a project that by conducting thorough diagnostics, using our stakeholders to really identify the root causes of the problem and applying appropriate interventions, timely outcomes can be achieved. A great indicator that we have gotten to root cause is that the interventions and the outcomes have now been sustained over time and continue to perform well 18 months later. Thank you very much.
Thanks, Brianna. And I'm glad Mr. Morris was here to see the sustainability in that work. Okay, fantastic. We will get to questions at the end, but it's with pleasure that I'm going to introduce Susan Nunn. She is going to talk about group therapy for emotion dysregulation and self-harm in 16 to 24-year-old young adults. So thank you, Susan.
Thank you for your interest today. I stand here today on behalf of our young people and their families. We have children, adolescents and young people who are unfortunately attempting their own lives, engaging in quite serious self-harming behaviours, including overdosing, and are managing extreme, strong emotions. We have families who are confused and who are unsure about how best to support them. And at the time when they reach our community mental health team, some of our clinicians are uncertain of what they're walking into and how best to help them. And in 2018, I led a proposal to SALN to introduce some group therapy programs to address this client group and try and get some evidence-based practice and treatment into helping some families who are in desperate need. I'm the lead clinical psychologist in a multidisciplinary community mental health team who receive referrals of young people aged 16 to 24 years of age with serious presenting mental health concerns, and usually after attempts of their own life and serious self-harm. When we did a review of those who are on our books who were self-harming, they were about 20%, and 50% had experienced extreme emotion dysregulation or difficulties managing their emotions. The statistics we're presented with are quite frightening, with these people not receiving treatment, and the impacts are quite far-reaching. There are economic costs listed in front of you, which we are all well aware of, but they are quite expensive and they're quite far-reaching. Furthermore, if we look at it from a biopsychosocial perspective, which we do in our treatment, we have the additional impacts of genetic vulnerabilities, of poor physical health outcomes, of high psychological distress and comorbidities, including drug and alcohol abuse. We see presentations in and out of our emergency departments and in our community health services. And within families, we experience breakdowns. We see difficulties with managing finances. And for some of our young people, we see them entering into state care. I led the introduction of a 10-week group therapy program for young people who are engaging in self-harm or overdosing. This is a CBT-informed group that's based on developing skills in social problem solving to improve relationships and communication. We have an international DBT, dialectical behaviour therapy group that's been empirically validated and tested across the world. And in the last decade, there's been the introduction of a parent-child format for this group program, where the parent and the child attend the group together and learn the skills at managing strong emotions and improving family relationships together in the group to take home and impact that wider systemic network. We see skills in mindfulness, interpersonal effectiveness, managing distress, managing emotions, and a particular module for families called Walking the Middle Path, which bridges validation within the family, behavioural changes, and the ability to balance dialectics when both the parent and child can be both experiencing truth within their statements at one time, but it comes together with a synthesis and a collaboration of understanding. This wouldn't have been possible without clinical and research partnerships and a public-private partnership. We have our public Salin mental health service who are contributing a significant amount of clinical resources to this project. But the project wouldn't have been able to be coordinated and funded if it wasn't for our partner of the James and Diana Ramsay Foundation, a philanthropic foundation here in South Australia. They have a particular focus on youth and vulnerable groups, and it was a passion of Diana Ramsay, who was a sportswoman and a social worker, a community advocate for women and children, who's made great changes in the state with all of the wide-sweeping programs that the Ramsay Foundation have introduced. Early intervention and the impact of research in the real world is a fantastic initiative and passion of Breakthrough, and they joined us in helping to broker this relationship with the James and Diana Ramsay Foundation. And the partnership with Flinders University has been particularly around looking at translating research with our clinical practice, because we're already delivering the clinical practice and the researcher came along to see if it's actually making a real life impact. And with Salin, we were continuing to provide our treatment with severe mental illness, but now had evidence-based programs to support that. We've just entered our third year of funding from the James and Diana Ramsay and Breakthrough Foundation with that collaboration. Initially, we had to look at ethics, policies and procedures, develop a group eligibility criteria, training plans for our staff, and it helped us with looking at the adaptation of a feasibility focus within our research, looking at recruitment, referral pathways, eligibility and engagement, and attention, acceptability and adherence to the program. We've looked at measuring treatment costs, and I'll look at the clinical outcome measures with you shortly. Here they are listed here. I won't go through them in detail, but they were particularly targeting the areas of change we'd like to see in our young people and also a supporting family member. I'll have some graphs with the clinical outcomes coming up to show you shortly. We have smaller samples for our groups, but please keep in mind that one of the groups goes for about 5 to 6 months, and it is pre and post data that we're collecting for these groups, and it's quite an intensive program that the families have to go through. Here we have some data on our adherence rates. What I can highlight here is that the retention in groups was higher than expected than what we see in the literature, and also the type of treatment that we offer incorporates homework completion, practice and reporting on those results and skills, which keeps those scores up and keeps adherence strong within our groups. I'd like to share with you some qualitative data from both our CBT and DBT groups. Particularly, I'll highlight here a young person who has the power, and some of these people are as young as 16. This group has helped me more than any other therapy I've ever had. And it's easier to do these sorts of programs with people who have the same problems as you. We think about what a young person's world is like as a 16-year-old. And for those who are going through the DBT group, towards the end of the young person's qualitative feedback, if it wasn't for this group, I wouldn't be here today. And from our parents and carers, my child was in some really dark places, and now we have a shared language. I won't go into detail of all our clinical results, but I will highlight some of the bolded areas, particularly as we look at our DBT group results and our CBT group results. We have large effect sizes in the ability of young people to manage strong emotions. This is the target within the DBT program. This is the target for people who are attempting to take their own lives as a result of strong emotions. We have moderate to large effect sizes for suicidality, for those thinking about or entertaining the ideas of taking their own lives, and also for those who are experiencing high amounts of distress. Within our CBT group program on the right-hand side, we have indicators that there could be an effect there for managing distress as well. I have some of these depicted in graphs that I'll just move through, but we can see the changes pre and post. Firstly, in that suicidality change for young people. Also in emotion dysregulation and distress. We're not comparing the two groups together of DBT and CBT, but you can see the changes pre and post. Some really interesting and important results for us to look at are the clinical changes within our parent and carer supports. Again, in the bolded areas, I'll draw your attention to the changes in carer burden, so the impact on the carer to be able to care for that young person and others in their family, as well as attend to other demands upon them as a parent or carer, and also emotional climate, so the ability for the emotional distress and nature of strong emotions in the home environment to be managed. And we're seeing large effect size there for the carer burden, and also small to large effect sizes for expressed emotion within emotional climate. And just some depiction there of that one on the graphs. In summary, we've had high levels of adherence and acceptability, and our dropouts have been better than what we could have anticipated. We're seeing young people who are improving in the management of their symptoms, including with living and living that life worth living, and parents having a reduction in the burden on them with being able to care, and also increasing their ability to manage within the family home. We do know that consumer preference for an individual treatment format is usually always preferred by a young person, again thinking about the stage of change they're at developmentally, and motivation to do that in a group who are severely, usually anxious or depressed, is a significant impacting factor on our treatment numbers, but something that we'll work on in this third phase of the assessment and research. I'd like to share with you some of the many positives that we've achieved along with some of the numerous challenges. So we've adapted our service model now to include encouragement for and participation in groups. We've got rolling entry points so people can step into our programs every 4 weeks, and there is no waiting list, and there won't be a waiting list. We maximise audio-visual materials to engage those who are potentially on the spectrum or have difficulties with their literacy, so that is no barrier. They've probably already missed a significant amount of schooling. Externally referred clients into the service don't rely on the tertiary case management of our community service, so we're lessening the workforce impact at a time of great challenge. We've embedded a researcher in our clinical team. We have continued support of our funding bodies, now into the third year of funding with the Breakthrough and James and Dinah Ramsay Foundation. We've had our CEOs, our clinical directors and many dignitaries attend our graduation ceremonies of our DBT groups to hear from the young people and their family members about this impact. And we've got increasing awareness of our group programs through in-services, job advertisements, and I presented a few months ago at a national conference with some similar outcomes I'm talking to you about today. However, we've managed challenges including turnover of staffing, recruitment of young people into groups during the chaotic lives of young people, We've worked through COVID-19, which is when we launched this program, and we adapted with telehealth. So if a young person's isolating or COVID positive, they can still participate in every group, which is on every week. And we've had support with SALN with staff training and recruitment and retention of staff. And a couple of more slides to finish. I've listed here some service plans for us moving forward and some research plans as well. I've talked about our service model. We're now incorporating communication of clinical outcomes to families to increase that motivation for treatment at the start. We're increasing a number of groups, including a graduate group, for those to come back and offer peer support to others. Capacity building also includes linking further with university placements, and I'm a university supervisor, and I've incorporated my students into co-facilitating the CBT group to impact that workforce demand. And also we're looking at SALN adopting the ongoing funding of the group coordinator position for the continued impact into the lives of these young people. A pending publication, a health economist working with Flinders University, and further analysis of our clinical results is where we're heading. If you would like any more information about referrals, inquiries, or about the work that we're doing or the collaboration with our funding bodies, I'd encourage you to get in contact with me. I just wanted to finish with highlighting this has been quite a successful SALN pilot project that's made a significant contribution in terms of the collaboration between the public-private partnerships, a philanthropic group, a university, and families within our SALN area. The opportunities have great expansion, diversification and research based on our knowledge so far, that we have so much research that we couldn't possibly apply ourselves to it all just to publish it at the moment. We need some help with that. We've got opportunities for how we could extend out these groups to other areas across South Australia. And I was provided with a couple of voices to bring with you today. One we saw on our slide earlier from our young people, that this is more than just research. This is actually people's lives. That was from a 16-year-old young female. And from a graduation group that happened on Monday this week, a father shared with us that he owes his daughter's life to this program. Thank you for your time and care. Thank you.
Thanks, Susan. That was amazing. A very important program for our most vulnerable in our community. I know I was very touched by that, as I'm sure everyone else in the audience was. We will get to questions. I do have some questions for you in a moment as well. So, but we will head to our next group. So, with great pleasure that I invite Diana, Chen and Karen to the podium, and they're going to talk about the Gift of Hope, the Stroke Lived Experience Poor Support Program, SALN Inpatient Rehabilitation. So, welcome team. And I will just note that actually this was a CIP that we had, and we always encourage our consumers to be involved in our programs, and so it's really great to have you present today. Who would like the microphone?
Hello, I'm Karen and I'm a lived experience volunteer.
Hi, I'm Chen. I'm the nurse unit manager of Tobruk Rehab Ward.
And I'm Diana. I'm the volunteer patient and family representative, lucky enough to be working with our lovely rehab teams. I'd also like to acknowledge that Rika Chidlow couldn't be with us today, and Rika Chidlow is our stroke liaison nurse. We are very excited and grateful to be here on Kaurna land today to share what we believe the Kaurna people have always known, that healing is about the whole person and is a community effort. We reached out to the community and now have wonderful volunteers like Karen, who themselves have experienced a stroke, generously visiting our wards to connect with our patients and their families. We have titled our talk, The Gift of Hope, because that is the feeling that most patients report after their conversations. And as the African-American poet Maya Angelou said, people may forget what you said, people may forget what you did, but people will never forget how you made them feel. On our rehab wards, we knew we were supporting our patients' recovery well, but could we be doing more? As you can see, this is how our patients are feeling. our patients and their families can struggle emotionally both during the hospital admission and on their return to the community. It is not surprising. Stroke is an illness that strikes swiftly, challenging much, including a patient's sense of self, independence, security, and ability to lead their former life. There can be much grief, anxiety, depression, and search for purpose. In 2019, we already had our first lived experience stroke volunteer, Viv Wilson. We were already hearing comments like, "Speaking with Viv was my Florence Nightingale moment," and how positive it was to speak with someone who had been there. So we decided to expand our lived experience peer support. Hopefully, this would not only enable helpful and at times life-changing conversations, but also build up awareness of peer support and the lifeline it could be in the community. And indeed, Karen does now make peer visits into the community. Over to Chen.
Thank you. We always need to select our volunteers carefully because it can be a very impactful role. So we developed a role description and expression of interest form. We were particularly interested into the responses of the question, what are the most important messages you would like to convey to our patients and families? We also developed the procedures for orientation and ongoing support. We particularly focused on team building with the aim to ensuring that our volunteers felt supported and valued in the team. Whilst acknowledging the sample sizes are small, but as you can see that both the patient and staff felt that this lived experience peer support program has made a positive difference in the patient experience and their stay on the ward. And also our staff lived experience volunteers and our staff also feedback that is very positive. They made a positive changes, and for the lived experience volunteers, they felt that they will recommend the role to others.
We were also very pleased at the number of staff who took the time to give free text feedback, an indication of the value that they placed on the programme. These are just some of their comments. And now it would be wonderful, please, Karen, if you could just speak with us about some of the experiences that you have shared with our patients.
Thank you. Every time I go to the ward, I have a different experience with different stroke survivors. One that really stands out in my mind was a lady who I knocked on the door, went in there. She was on a bed low to the ground, but she was not facing me. So I said who I was, and she turned over a bit dopey. And I said who I was and if I could come back later, and she said that was fine. So about an hour later, I did go back into that room, as I said I would, and I sat with her and said, "What are you doing today?" Because usually they're up and about doing a whole heap of rehab, which is what they should be doing. So she said, "I'm having a mental health day. I'm doing nothing." Okay. So I started digging a bit deeper as to why she was doing nothing, and she was quite depressed, as I have been from having a stroke, so I understood where she was coming from. So I talked to her about her life prior to her stroke, things that she enjoyed, things that brought her joy, and one of those things was gardening. So we looked outside of her window. I said, "Well, look at that beautiful garden out there, trees, bushes, you've got the sunshine happening. Do you want to get back to your garden? Yes. Well, the only way of doing that is to get off your butt and do something about it and not lie here. So with that, I left her. And about half an hour later, to my surprise and joy, she was being wheeled in a wheelchair by 2 nurses, and she was gibbering to them saying that this young blonde, thank you, young blonde, volunteer had come in and given her the kick up the butt that she needed. So she was off to rehab. And I'm really pleased to report that the following week she wasn't there, which was great.
That's absolutely tremendous. And as I mentioned, Karen has also been out in the community and will share with you, it's not just about the patients, it's about their loved one as well, and their life is turned upside down. And so this is the experience of a husband. Thank you, Karen.
Thank you, Diana. As Diana mentioned, I do go out and see stroke survivors in the community, people who have gone into nursing homes or are trying to make their lives what they used to be when they're back home. But this one was a little bit different. This was the husband of a lady who'd had a massive stroke who was actually in a nursing home. He was finding it really difficult to cope with. They had been married 50 years. They did everything together. And suddenly, like hers, his life stopped. He was lost, he didn't know where to go, he didn't know what to do. He felt guilty thinking about doing anything other than looking after her because that was his life. So after a few coffees and digging into a lot of stuff, one of the things I recommended for him to do was to join some sort of club or group, like Lions or Rotary, something like that. He wasn't really a reader, but I got him into a really simple book, Who Moved My Cheese? You might know of this book. So I think the penny dropped when he read that book, and that change does happen and you have to move with it. And so he started making some changes, and we'd met quite a few times. We had a walk along the beach, we had lunch in a cafe, we've had coffee several times, and next week actually I'm going to ride my bike with him because just before his wife had a stroke, they had bought 2 electric bikes, but they didn't get to use them. And I do like to ride a bike since my stroke. So next week we are riding together. Cross fingers the weather's good because we've had to postpone a few times. So he has actually become my friend. And I just think that's wonderful. It gives me joy that I have another friend. It gives me joy that I have helped him move on with his life and not feel guilty about going and meeting a friend for coffee. I mean, he goes to that nursing home twice a day, spends hours with his wife, feeds her, makes sure she's comfortable. She doesn't recognise him, but she still gives him a big hug and kiss when he arrives and when he leaves, which is lovely. And they're special memories for him. So this person and I, we will continue our journey together. He has just sold his house with all those memories and moved to somewhere smaller where he can start some other life. Not a new life, it's just another life to the one he's still got with his wife in some capacity. So I'm really privileged and proud to be part of that.
That's absolutely wonderful. Thank you for sharing, Karen. And lastly, what has been the impact on you, Karen, of actually being a volunteer with us?
Huge. So at the beginning of these slides, it was the gift of hope. And we talk about hope, and when you've had a stroke, hope is a very large word. I lost my identity. I lost hope. I lost who I was, and I didn't know what to do. So, besides working really hard in rehab, I had to find a new life's purpose. I had to find a reason to get out of bed, something that made me want to do things. And volunteering is certainly a huge part of my life now. I do volunteer in a stroke capacity with other organisations, but I love what I do here at Flinders.
Thank you so much, Karen. So how can you follow on from that? We love it, the patients love it, families love it. We just want to do more of it, and we love working with our staff. So we're just going to keep on going, and we might come back and report how we're going at the next Silence Research Week. So thank you so much.
I don't know about you, but I could sit and listen to this all day. It's amazing. So we've got our last group, and it's with pleasure that I invite Rebecca and Shane to the podium on behalf of Surat Martin, and they're going to be talking about foot stomp. Look after your feet. So welcome. Do you want to talk to the mic?
Hello everyone. Pardon? I can use that, that's fine. Can everyone hear me okay? Perfect. I'd just like to start this presentation by providing an acknowledgement to the land that we present on today is the land of the Kaurna people. I'd like to acknowledge the gratitude that we share this land, our sorrow, for the costs of that sharing and our hope that we can move to a place of justice, reconciliation and partnership together. I pay respects to elders past, present and emerging, and Aboriginal and Torres Strait Islander peoples from different lands that are here with us today. I'd also just like to acknowledge that this project wouldn't have been possible without the support and funding that was provided as part of the Aboriginal and Torres Strait Islander diabetes-related foot complications project. That's quite a mouthful. That has been funded through the Indigenous Australians Health Programs, the Commonwealth Grant. And I'd also like to acknowledge the team behind the project, and that's included Teresa Francis, who's from Karpa-Narrantendi here, Saraid Martin, who we've defaulted, Shane and I have been brought in on the fly. Nick Licorices, who was our allied health, our Aboriginal health practitioner, the AFC team, so Aboriginal Family Clinic teams, and the Sep Research team, which Shane is part of as well. So ours is a little bit colourful, so you can focus on the colour. So this is really our journey so far around the foot stomp, and it demonstrates the intersect between quality improvement and formalised research. We've not reached the end yet, and in some ways it actually feels like we've just started. And when we look back and reflected at the start of the project, we would not have imagined that the direction that it's actually taken thus far. And we hope that this presentation will be insightful and perhaps show you what can be possible, particularly in relation to health service-driven research. This artwork was actually designed by Nick and obviously has a story associated with it. And the left foot presents the vascular supply to the foot, and the right foot the nerves, and the inner circle are the community working together, and the footprints walking the journey with family, community along songlines with healthy feet, because that's really been the focus of this project. Some of the rationale for looking at these grants is that diabetes foot complications actually 3 to 6 times increased in the Aboriginal and Torres Strait Islander population. And these foot complications can involve ulcerations of the feet, infections or amputations, which is certainly something that we all try and strive for to prevent. And actually in Saalan, there are no public podiatry services for Aboriginal people that are at low to moderate risk of diabetes-related complications. We certainly have a well-established tertiary pathway for active foot disease, yet anecdotally there's actually been very limited interaction with the Aboriginal patients' referrals and presentations. So there's very limited preventative early detection services, and it's also apparent that there are barriers in actually accessing care in these established pathways. So So just a little bit of a timeline in regards to the Foot Stomp project. So in 2020, the Saaland Podiatry and CARPA team secured a $150,000 grant from SEMRI, and we named our project the Southern Foot Stomp, and it's just been shortened to the Foot Stomp. And a project coordinator was recruited in July 2021. So you can already see there's been a bit of a lag, and there's some of the learnings from the project in regards to recruiting and HR processes, which I'm sure we all laud. So Saraid actually was the podiatry project coordinator. Saraid Martin, she's actually on leave, that's why I'm up here now. And that position was actually for 12 months, which was meant to end in October. It was meant to end a little while, but there's been some delays with COVID. And again, you see there's another lag with Nick, who was our Aboriginal health practitioner in training. He was recruited in October. And Aboriginal health practitioners are fairly rare. So we were very lucky to secure Nick into the project for a little while. Unfortunately, Nick left. So Saraid and Cara Lees are finishing off the project, which ends in October. The aims and objectives of this project have actually evolved, and the opportunities have emerged to expand the remit of the project, and are now and how we were actually going to evaluate this project. So a really key component was the employment of the Aboriginal health practitioner, and Nick was employed 3 days a week at Point 6 to work on this project with a very specific focus on community engagement and upskilling in regards to advanced foot assessments and treatment skills. We also engaged the Saaland Aboriginal Consumer Group, and 2 volunteers from this group actually agreed to sit on the project reference group, which is absolutely vital. And other stakeholders in the reference group included Saaland Aboriginal staff and key leadership team members and an Aboriginal NGO representative. The Foot Stomps had a very strong presence in community events when we've been able to sort of run these, and the artwork has been recognised, and it's a real brand that's very strong within the community. This has obviously been a really challenging part of the project due to COVID-19, but there was creativity aplenty. So it really started with a quality improvement focus, and it became very apparent there was an evident gap in the literature around what was actually culturally appropriate in regards to developing a podiatry model. And this planted the seed to our next journey leg, which is to undertake a more formalised research approach. And it was recognised that the project team didn't actually have the research experience and expertise, and that we needed to develop a collaboration, and that's where we headed. So you can see from the goals, and we've actually used a variety of methodologies to get to this point, which included quality improvement, formal research, and this has formed the basis of our evaluation for our Foot Stomp project. The continuous improvement project objectives are outlined, objective 1, 2 and 3, and ultimately looked at increasing the diabetes foot screening rates in adults at the AFC. So that was a separate project that Saraid actually undertook. And the bolded objectives actually outline the research that's driving the next part of our project and that journey, and that'll actually be presented by Shane. So thank you.
Thanks, Beck. Yeah, hi everyone. I too acknowledge the land that we meet on is the Kaurna, land of the Kaurna people. Just by way of further introduction, I work for Flinders University as a research fellow in Aboriginal and Torres Strait Islander health, and my people are the Guggatha people from Ceduna and surrounding areas, if you know that area. Okay. Just to take you through some of the practical steps which occurred next. So Saraid liaised with the Saaland Research Coordinator Aboriginal Health, some may know as Jess Stott, around developing a partnership with Flinders University. That was specifically a conversation with Associate Professor Tamara McKean, who's a Wallian woman, and also a medical physician, and it was around gaining expertise and support required for the research. So in collaboration, they developed a proposal and the methodology, and the project team collaborated with the Saaland Aboriginal and Torres Strait Islander consumer and community group around the aims of the research. We later talk about that as being one of the key learnings of early engagement. And also in collaboration completed 2 ethics applications to the South Australian Aboriginal Health Research Ethics Committee and also the Southern Adelaide Human Research Ethics Committee. So as we heard earlier, there were 8 initial objectives of the Footstomp project and 2 specifically related to formal research evaluation component. So those 2, just to highlight them, is to map consumer foot care journeys to understand how the current model of foot care delivery is reflective of the community's needs, expertise and priorities. And secondly, to co-design with consumers utilising a decolonised framework, a preferred model of foot care service delivery that is reflective of community needs, experiences and priorities. Flinders has done quite a bit of work in decolonising practice, and there's much that can be said about that, but just to pick out some of the elements of decolonising practice that we acknowledge, led by Aboriginal and Torres Strait Islander ways of knowing, being and doing, strengths-based, breaks down systemic racism, and challenges the power imbalances in all structures formed by society. So we were able to bring that into the framework for this project. So our hope through this research is that we can provide an opportunity and platform for Aboriginal consumer voices so that we can better understand how to enhance and strengthen early detection and prevention models of foot care. And the secondary outcome was to produce and submit a co-designed, decolonised foot health service model of care to Silent executives for consideration, translation into practice. Okay, in terms of our methodology, a multi-methods design was used for this project to provide rigour and increase the body and validity of the evidence available to evaluate the impact of the project objectives. So specifically with regard to mapping consumer foot care journeys, an Aboriginal patient journey mapping tool was used. And with regard to co-designing a service model of care, a series of yarning circles were conducted with Aboriginal consumers. So Aboriginal researchers from Flinders University's College of Medicine and Public Health, which is where I work, conducted the face-to-face data collection with Aboriginal community. And this approach acknowledged the importance of holding Aboriginal space in data collection, ensuring a culturally safe space where Aboriginal knowledges could be shared and experiences around foot care practice could be shared. So in terms of the patient journey mapping process, we use purposive sampling for our recruitment approach. Aboriginal participants known to the research team and who accessed the Silent foot services were invited. We used the Lowitcher workbook, Managing Two Worlds Together, which informed the questions that would be asked of patients and staff, and timeframes were mapped of all interactions relating to foot care from patients' case notes. And also in terms of community yarns, we used an opportunistic and snowballing sampling approach via community networks as well as some other communication strategies as well. Just to mention some of the other considerations during data collection, we offered transport assistance to and from the venue. We made refreshments available. A variety of venues were used, given we had community living in the inner south and some in the outer south as well, and also we offered reimbursement in the form of vouchers to participants. Okay, so just to highlight some of the learnings which within the team, they were many and varied. Aboriginal and Torres Strait Islander people have a long and proud history of caring for people and country, and that was evident in the really rich data which we were fortunate enough to participate in through our yarning circles. And the importance of truth-telling, acknowledging both Australia's history and also Silent history was really important as well. Adopting decolonising approaches when partnering with Aboriginal community. So again, talking about approaches which are strengths-based, Aboriginal-led, challenging power imbalances and so on. Making no assumptions around barriers to healthcare, which are vast and run deep. The importance of building partnerships with consumers and staff from the beginning of the project in order to maximise impact during implementation. Building trust and rapport with community. Fortunately, we were able to utilise skills and expertise of Aboriginal researchers, which we considered vital during the data collection process. Hosting yarns in a culturally safe space was also important. So one of our venues had a Ghana cultural exhibition on show, and it really did provide a great foundation for community to walk in and walk through, and led to an open conversation. It actually really helped. So, and the other thing was, it was felt that research can often be a slow process, especially when submitting to more than one research ethics committee. So not to rush and allow for lots of contingency time. So just to highlight some of our preliminary findings. So with Objective 1, we've currently mapped 2 patient journeys and 2 staff interviews, although we haven't analysed that data yet. In terms of Objective 2, we've conducted 4 community yarns with 33 participants in total, all being Aboriginal people over 18 years living in this Sarlan catchment area. And some of those preliminary findings from the yarns are that there are barriers to accessing foot care services for Aboriginal people, including inequalities of access, costs of private services, shame associated with accessing services, communication barriers between staff and patients, and past negative experiences. And so accordingly, Aboriginal consumers do make a compromise on their own cultural safety when engaging with podiatry services across the health spectrum. Aboriginal people value good foot health and know about what affects feet, and not just how to care for feet, but have extensive knowledge into caring for feet. With culture, many stories shared around culture and traditional practices. So in terms of a model of foot care, Aboriginal community know what they would like the model to look like. But in their words, they talk about it being flexible, culturally welcoming, holistic. It should consider traditional remedies and things like bush medicine, an essential part of that, and have a health promotion and a treatment focus. So just my last slide is our next steps and where we're up to. So we still need to complete data analysis, particularly around the patient journey mapping. Still need to finalise our reporting to SAMRI and internally. Using the analysed data we have so far, we're looking to formulate a business case for ongoing health services in Sarlan. We need to provide feedback to the Aboriginal community as an essential part of this process, and publishing our findings as well, and including more conference presentations locally and nationally. And thank you.
Okay, we are running a little bit behind, but I'm going to ask the panellists to come back up to the chairs here if they wouldn't mind. Thank you. Okay, so I will firstly go, do we have any questions in the room of our presenters? Over to Dom in the back there. Thanks, Tanya. Great.
They were all excellent presentations. Thank you so much. My question is for Brianna, and it was prompted by some of the other presentations that spoke about the consumer experience. So obviously you achieved your goal of increasing the utilisation of the Marion Priority Care Centre, but I wondered, did you do any work around whether the people who utilise that service actually found it met their needs and they were happy with the care that they were provided?
Well, I was going to say that's probably a bit of a gap. We didn't do a formal assessment, Dom, but I can tell you that I was there with my husband 2 weeks ago, and it was a day that the service saw 40 patients, and I was listening to conversation in the waiting room, and I have done this in the past as well on other occasions, where a mum said to her probably 8-year-old son, you know what, they told us at Noarlunga that we'd be waiting 5 hours if we needed to get your head glued there. she goes, what's 10-minute drive up the road if it means that we get seen so much quicker? And so I think, we have a lot of anecdotal, haven't done any formal surveys or anything, and who knew that we were going to exceed our initial targets so significantly, but definitely the feedback. And I do refer everyone I know to the service as well. That's probably how we got to the 140. And the feedback that I've had from everybody is absolutely positive, and how much it saved them having to present to an emergency department. I don't think consumers want to present to an emergency department if they can help it, but accessing GPs and things like that leads at the moment is so difficult that if we can actually find where appropriate, that we're not just doing a GP replacement model, that we can actually get patients seen in a lot quicker time frame. People are very happy.
Fantastic. Actually, this is a question from Hoover, and it's the same question that I had for Susan. Susan, you mentioned in your group therapy classes that your attendance rates were actually higher than the literature. Why do you think that was?
So in the literature, the attendance rates reflect a person attending the group on their own without a family member. And I think definitely the family member's involvement in the group therapy treatment would have an impact on that in keeping each other sort of honest to the commitment that they both undertake, say for the 5 months. I reflect in the graduation group that we had on Monday, and a family shared that when they first started, the young person walked in and it was completely what they didn't expect. They saw some young people doodling on pads. There was someone else who was playing with some fidget toys, and someone else who was self-regulating with another skill, and they actually felt quite validated and understood within that context, rather than expecting they were walking into a classroom where they weren't going to be perhaps at the same level of literacy level as others. And a mother also shared that she came into the group and felt completely overwhelmed at that point and didn't think that they could continue on. And another parent said to them, just try it out for a few weeks and keep going. And she said she kept coming back for that other parent's encouragement for the first few weeks, and then they completed the 5 months and they graduated together. So as much as I'd like to say it's the treatment facilitators and everything that we do, I think it's the peer work and the encouragement from each other that gives people a sense of validation and community.
And I'm just going to stay with you for just a moment, because the next question is also for you. Is there any sense of whether outcomes or satisfaction differed across telehealth and in person? And especially as the young people who might feel very familiar with online technology, and could it be a preferable option for some?
We adapted our group norms to telehealth when we particularly went through the Christmas lockdown period last year, and the young people and families were very responsive to that, and that perhaps limited some of the impacts or challenges you would expect with telehealth, including people having out of view access to using their own devices or distraction or engaging in other activities. We ensured that young people and their family members were both on the same screen, so it kept the family in the same room rather than the young person being in their bedroom and the family member being at the kitchen. We also encouraged that people engaged in all the content. We used a lot of emojis. We adapted more audiovisual materials for that platform, used a lot of videos that were developed out of America and DBT institutes for young people for COVID-19 isolation times. So we definitely adapted with that. I think people much prefer just being in person. We haven't gone back to having all our snacks. We're still all wearing our masks. But people are still engaging face-to-face, and I would say overall they prefer that because they actually want to get that engagement with other people in the room.
Fantastic. Do we have any other questions in the room? There is one more on here, but I just thought I'd double check. And this is for the Foot Stomp group. And it's actually also a question that I had in mind as well. So how can Silent embed strengths based on thinking and outlook from your project? And what I was really impressed about is really the due diligence to community engagement, the yarning circles, ensuring that you are co-designing from the very beginning. And so how can we strengthen and apply some of those principles to future projects?
I can probably start with the beginning of the project actually was around building capability and capacity within our existing workforce because there wasn't a service. And I think we've certainly achieved that, and I think that's where the project sort of evolved to now. Is that, well, there's a really big gap. Every other LHN has an Aboriginal podiatry service in regards to that primary care from cradle to grave, and that doesn't actually exist in Sarlan. And I guess that's where Saray started looking at some literature, and there isn't a lot around sort of getting the community involved in developing a model of care that may work for them, and hence sort of building those relationships with Tamara and Shane and his team Duncan as well. So I don't know whether you want to take over from there.
Yeah, thanks. One thing we did find was that there was lots of interest in participating in the yarning circles. 33 participants over 4 groups within 4 weeks was a real achievement, we felt. And the yarning circles, which we talk about, are quite different. It's a very different approach to qualitative semi-structured interviews, and it builds on connections within community. We hold groups with a size of around 8 participants, and within that group we build on connections, family connections, and it really does promote open, free-flowing conversations. So I think the community have always been interested in putting forward how their healthcare should be modelled and provided, and the data suggests that there are very strong views around what works and what doesn't work. And so I think there are existing mechanisms, there are groups that exist. Part of our governance structure was to incorporate a reference group which informed our data collection. It informed the way in which we went about our analysis and many other aspects of the project. So the Aboriginal community are really keen to provide sort of input into the way in which Sarlan works. So I think it's just ongoing partnerships. I think this has been a really good example where Flinders and Sarlan have partnered around really capturing community voices and building that in, and hopefully we can put that into into translation, into practice. Yeah.
Just add that we work in a very medical model, especially in an acute system, which is very challenging. And I guess, these are some of the learnings coming out of the project, how we could actually do things a little bit better. We've done a cultural safety audit in our specific area, and we're across 3 sites to look at how that area can be a little bit more welcoming to our Aboriginal and Torres Strait Islander populations, whether it's sort of within the south or, our visiting peoples as well. So, I think that there's lots of little things we can be doing. Cultural awareness training, which is really important, asking the question training as well. So, we've started to sort of build on that.
We're going to have one more question in the room. Diana?
I'd really just like to say that all of the presentations were absolutely amazing. I don't know if you noticed in our presentation that Karen was wearing lycra in her last. She actually didn't ride from being a schoolgirl till after her stroke, and that was one of her challenges that she took on. And I'm just doing a plug for lovely Karen, because she's actually going to ride in the Tour Down Under 84Ks January next year, raising money for our stroke people, which is amazing, absolutely amazing. So if you're interested or you want to pass the word along, there's a little flyer on the table outside which you can scan, and it takes you to the Flinders Foundation for fundraising for that. And we're hoping to raise enough money so that we can get a card so that people can actually practice transfers and go home more confident so they can really get into the community. So that's what we're looking for. So thank you very much.
Fantastic. Thank you, Diana. All right, I think we're going to go to an afternoon tea break in a moment, but just a little reminder to vote for your favourite presentation via the Hoover app. And if you've got any more questions, I'm sure the panellists will be happy to answer any more questions in the break. So again, thank you very much to all of you. might get started. I'm going to talk into this one. It's a bit more clearer. Thanks for coming to our panel session. And the title of this session is The Importance of Understanding the Problem and What is Causing the Problem before applying any solutions. So thank you all for staying for the 4 o'clock session. I do know that there's quite a number online as well. And I've been really, really inspired this week by all the presentations and all the presenters. And I thought it was timely, actually, that the theme of research this week is to acknowledge our history and our partners and discover the future. And I really do want to acknowledge Professor Rob Padbury and the Division of Surgery for their dedication and vision for continuous improvement, which has, started at least a good 20 years ago, and also to Jane Basham, who's also in the room, is going to be part of the panel for being part of that journey over the past 20 years as well. So really do want to acknowledge that history, and it makes me really excited to reflect about our future. And Grant very adequately talked about in his presentation today that Sarlan is very well placed from an improvement perspective because of the vision and the dedication and hard work of the staff that have gone before us. So I do have a couple of introduction slides, and I do want to acknowledge that we are meeting on Kaurna land and pay my respects to elders past, present and future. So what do we mean by problem solving and acknowledging and understanding the problem? And we talk, and this is one of the slides that I've taken from our continuous improvement program here at Sarlan, and we talk about the importance of mindset. So the fact that actually problems are good. And so no problem is a problem here at Sarlan, and we have a structured approach to problem solving, to go and gather facts, the importance of going and seeing to really understand the problem and going to Gemba, as we say, at a place of work, and making sure that we understand that it's process-driven, so that we understand the problem from beginning to end, and we have a shared understanding around how we're going to problem solve the problem. We want to empower our staff, so the people that do the work to be involved and empowered to design and problem solve within their local environments. And we talk about within our training around providing opportunity for staff to do this, providing the skill and the skill set to be able to do it, and also the time. And so here at Sarlan, and Grant talked about Intermountain Healthcare, but we also, have adapted and evolved our problem-solving framework. We use the Sarlan 8 steps to problem-solving process here, and we do have our own in-house faculty that teaches problem-solving and guides Sarlan staff through that problem-solving methodology. Okay, so this is a quote from David Verbal. Common mistakes in problem solving is assuming you know what the problem is without seeing what is actually happening, assuming you know how to fix a problem without finding out what is causing it, and assuming the action you have taken to fix a problem is working without checking to see if it is actually doing what you expected. And so, in other words, not grasping the situation. And we're going to talk a little bit about that today. So this is our Sarlan Continuous Improvement Framework. Be very well known for most of the people in the room here. And what we are really talking about is the first 4 steps around ensuring that we understand the problem in detail before jumping to any interventions or solutions. I've got a little bit of a video here, and I'm hoping this is going to work if I press this. Oh. Sound.
Oops. Escape. Where's it? You want to start again?
Sure. Thank you. I think a very good example of the importance of understanding the problem. Okay, so I'm just going to skip through this very quickly. Grant, we're going to come back to this, and I'm going to hand over first to Jane Basham. So Jane Basham is an improvement coach with the Sarlan Continuous Improvement team, has had over 20 years of experience working in improvement and process design, and has been part of the redesigning care team at Flinders Medical Centre since its inception in 2003, which is now the Continuous Improvement Unit. Jane is on the faculty, which delivers the Continuous Improvement program within Sarlan, which focuses on supporting participants to problem solve using the Sarlan Continuous Improvement framework, as well as in problem solving and process improvement field within the Southern Adelaide Local Health Network. And Jane is an adjunct lecturer at Flinders University and has co-authored publications in health and process redesign and lean thinking. Thanks, Jane.
Thanks, Angie. Well, I didn't realise you had to read all that out. Sorry about that. Okay, yes, the importance of understanding the problem and what is causing the problem. First of all, I'd also like to acknowledge the Kaurna people are the traditional custodians of the beautiful Adelaide Plains and pay respects to elders past, present and emerging, and recognise and respect their cultural heritage, beliefs and relationship with this land. We acknowledge that they are of continuing importance to the Kaurna people living today, and for you online, acknowledging country you may be on as well. Tell me and I forget, teach me and I may remember, involve me and I learn. So understanding the problem, well, in the Salin way, there are 3 components to that: data, mapping, but thinking about all the stakeholders, go see and show respect. Look, the Jefferson Memorial reminded me we have our very own story about animals. And the courtyard is here at Flinders is absolutely beautiful. It's got trees, it's got nature, you can hear water running, artwork, etc. And it's got ducks, and the ducklings are so cute. And then they become teenagers and adults, and people feed them. So this is a little story about, I had a focaccia out having lunch, and a duck swooped down and took half of my focaccia out of my hands, literally. Very aggressive ducks, and actually the ducks were they were getting very angry and aggressive. So a team, and I acknowledge Raj Shastri for doing this work, and also a team of people, but he got an expert in, and the expert said, because they wanted to relocate the ducks, but everybody loves the courtyard and quite like the ducks, and they said, well, actually you can't, because they fly and they'll just come back. So no, you can, primary industry said, we can kill them. Ooh, no, we weren't expecting that. And it didn't align with values of our organisation, and actually people really love the ducks and ducklings, so no, didn't kill them. But what was the root cause? Because really killing them's a workaround. They involved people who had a passion for the courtyard, and got people together, including nurses' forums and all sorts of different people. And the nurse said, well, why are they attacking people for food? And it's because they're hangry. And so she said, why don't we just feed them in the morning before everyone comes? And sure enough, that's what happened. Lo and behold, the sign is up, so people shouldn't feed them, but they're not angry anymore. And so when you go past that courtyard, you can think about the problem solving, and it's really getting the right people involved who have a passion for it, and solving things in a way that's satisfactory. So I'm just going to do a smorgasbord, I guess, of some of the ways we learn through deep understanding. And this is around medication errors and long medication rounds. What do we think the problem is? And so with data, we can see there are medication errors, that's SLS. But you may come up with all sorts of different right or wrong reasons as to what the problem is and what the solutions are. But what they did was go and see. And so they followed some nurses on rounds and had no idea how many interruptions there were, but it was significant. It was between 12 and 25 interruptions on a drug round. There was variability in the trolley setup. The trolleys weren't locked, the pill cutter was missing in action. When mapping, it was clear that being clear about roles and responsibilities, timing of work and safe processes. And one of the things they did when looking at the trolleys, the drug trolley in particular, and what was on it and taking stuff off, is on one of the trolleys they found some dentures. Sorry, I'm getting a bit emotional about it. And it belonged to a lady who was palliative. And, you know, the nurses on that ward had searched for those teeth and couldn't find them. And then they did find them. Anyway, I guess that really helped align people with the reason we're doing these things and for patients and what matters to patients. But by involving the staff who do the do, one of the key elements is when you try to do interventions, what sticks. And in trying to address the interruptions, they had a medication round, please don't interrupt. Now, if people had realised there are a lot of interruptions and then just told staff, you need to wear a vest, they would have said, no way, Jose. But involving them in the diagnostics, seeing the interruptions and then figuring out, as a group, what can we do about those interruptions, people started to trial things and they're on board with it. And these aren't used all the time, but when we notice the interruptions are going up, they know the solution that they can use at that time. Another thing I'd like to talk about is touch points. And in ED many years ago, they looked at experience-based design. And again, with that deep understanding, there was some interviewing of staff, interviewing of patients and following them around and looking at the environment. And one of the key things they found in speaking to patients was something that really called touch points, which was significant for them. One of the touch points was actually waiting. It was distressing. That's not new news to people. But one of the key reasons was because they didn't know why. And if people were told why, even though there was a lot of uncertainty around the waiting, that helped allay anxiety for a lot of people. And so that ended up being a key touch point. Another was when people arrive and have baseline observations, usually put a bunch of machines on that go bing, and then you do your baseline obs and you often don't take off the machines, and it's staff press mute on them if they start alarming, and probably they didn't need to remain on. Actually, it was very stressful for patients and their relatives to hear a machine go bing in their room, and they thought, oh my gosh, what is happening? Am I okay? And so again, in these touch points in finding out the distress that was causing, because a lot of the staff, and I used to be an emergency nurse, have domestic deafness to all these machines that go bing, but actually it was really distressing. So again, in doing this deep understanding, including patients, often there are some very simple things that can be value adding for them that we can incorporate. Goals of care is something that we're working on in this organisation, and again, in this deep understanding and getting feedback, consumer voices, junior doctor feedback and staff feedback. But as you can see, the words in each of these are quite different, and so there's fear, safety, trust. They're the things coming up with consumer voices. For junior doctor is not enough time. Where's the plan? 7-step, that end of life pathway stuff. And staff feedback was of a general thing. And as you can see, they're all different perspectives. And so in doing research that involves everybody, that's where you can start to deeply understand what you're needing to address. So with the diagnostics, there was an audit done, and that was clinicians interviewing clinicians and clinicians reviewing case notes. There were consumer representatives who interviewed patients. And out of the rich work that was occurring there started to be some themes. And overwhelmingly, participants actually value goals of care. But the language we started to realise wasn't goals of care, it's what matters to you, because the term of goals of care doesn't really connect with a lot of people. There was strong recognition about it's a holistic approach, not just end of life, and that most patients want to be involved and have the opportunity to ask questions. Level of experience, actually a number of staff felt more comfortable with it than we expected from these interviews. But importantly, not a lot of it got written down, or if it did, we weren't really sure where. It certainly wasn't in a consistent way. There was also a mapping, and you don't need to know the detail, you just need to know it's complex, lots of people, lots of variability. But then in understanding deeply, then there was some voting that involved a number of the key stakeholders and prioritisation of work. But really what I wanted to leave around this is the goals of care, the language is now what matters to you. And the tool, which is an infographic here, is simple, but it can empower patients and clinicians. But for the patients, if they're unfamiliar with the health environment, it gives them some framework for what they can think about and may want to communicate with clinicians. Clinicians really want to do quality care, and again, this can be used for them to help prompt and think about some of the things they need to include. But as this is an ongoing dialogue with those diagnostics, we're saying, oh, actually we haven't noted specifically spiritual and cultural things, and that was feedback that we received. But also, how do we make it culturally appropriate? And maybe there's other language that we can use when that's appropriate too, like have a yarn about what's important. Then there's a nice example from community services, the importance of understanding your problem, and I'd like to acknowledge Kirsty Delgust and Catherine Smith for this. They did some work around their aged care assessment program and focused on a high volume that requires output to meet demand. and that they really needed their flow to work in a more cheap way. The reason they've got an elevator is because an elevator is batching, whereas an escalator is one-piece flow. And we need to move out of elevators and into those escalators conceptually with our work wherever possible. So they did some diagnostics, again, to deeply understand. The mapping involved all of their stakeholders. A number of the staff had been there for years and didn't think anything could get better without a gazillion extra staff. They did some go and see activity follow, which identified issues. And also they did some measurements around their capacity and demand. And to their surprise, they figured out they actually did have enough capacity if they got a few things done differently. But again, if they hadn't involved all the staff in those processes, they would not have had buy-in. They saw some remarkable achievements. Again, it required all staff buy-in to achieve those things. But some of the reflections absolutely resonate with a number of the people who do improvement where we are. And that is that this methodology, the lean or the continuous improvement methodology, greatly assists in change management process as well as understanding the process. And so engaging the team understanding what the problems are and also contributing and saying what the problems are that they experience. Establishing the clear strategy, goals and targets. Ensure that you've got some measures so you can compare if you've made a difference. And there is huge power in understanding your capacity and demand. And it's actually such a fabulous way, by coming from a problem and deeply understanding it, you're well positioned to then do something about it as a group. Some of the CIP participants, so in the program that we run, I just thought I'd include a few beautiful quotes that people have as part of their reflections, and often they're not at the end of their piece of work, but it's been fun mostly. And this is during COVID times and absolutely hectic conditions. Change is possible, and the belief encouragement in the room is quite powerful at these events. Process mapping identified bottlenecks and delays that we weren't aware of. From this process, we've learnt not to jump straight to solutions, but rather break it down and analyse it, etc. So really, what we're encouraging is to define your problem, to understand it by going and seeing direct observation and data, set up some mission statement or a target, and actually get to the root causes using the most simple tools that you have available to you to clarify what they are. So why focus on understanding it and what's causing it? Well, actually, the output of a diagnostic is a deep and shared understanding of the current state. The next steps to improve it are usually obvious, but they're also importantly based on root causes. So I have some tips. Trust the process. What you initially think is causing the problem may not be a root cause. Look, there is actually never a good time, but in some ways there's never a better time. If you can make an improvement in our hectic environment, it will stick and will make a positive change for staff and patients every day. Start with the people in the room who have a passion and the patients and consumers. Learn to see value and waste from the perspective of the patient and persevere. If you want to know more, there are other opportunities for that. Thank you very much.
Thanks, Jane. Very passionate and some really great examples of really understanding the problem there. And I really love the duck example, so... Okay, so I'm just going to quickly click back here. Sorry. Okay, so I'm going to hand over to Grant now. So Professor Grant Phelps, for those that were here earlier, is a gastroenterologist with over 20 years of experience. And for those of you that may not have seen his preliminary presentation today, I really encourage you to get along to that. We heard about the attributes of being an elite organisation and how being elite is a choice. And actually, organisations just need to commit to being better at what we do. And by doing that, you will not only save money, but you'll be better than what the standard actually is. And we also learnt the importance of having the finance guy on your project. So I'm going to take that tip away. So Grant, over to you. Thank you. Here's the clicker, and I'll grab you a microphone.
What do you want me to do? Just talk?
Yeah.
Okay. Thank you. I'm a little bit slightly unprepared, so I'm just going to wing this. But
do you want a mic?
That's okay. That's part of the art of being a consultant. Thank you. Those of us who've been playing in this space see this fundamental problem made all the time that we don't deeply understand the problem. And to be fair, a lot of it's about us. You know, we're very much problem solvers as clinicians. We're trained to see a problem, fix a problem, next problem, and we've all worked in that sort of hurried environment. But I think this is the most important lesson of quality improvement, really. You can't improve quality unless you actually understand what you're trying to deal with, and that's the guts of this message. I'm really antagonistic at a personal level to some of the approaches we take, for instance, to root cause analysis. I think we've made that an unbelievably top-heavy approach, which says more about the sort of policy settings that are handed down from central departments than it does about what we're trying to achieve, which is as quickly as we can identify the problem, fix the problem, move on. So I must say my approach to that particular task is to do it really quickly. If we can't solve and we can't deeply understand what the problem is that's led to a significant event inside 2 hours with the right people in the room, then we've got a problem. And it says more about us. So that's just a random observation about how we do things. I think as a statement that hopefully you'll all agree with, beyond being solutions focused, I think we tend to jump to this sort of conclusion that Mencken said it well, every complex problem has a solution which is simple, direct and plausible and almost always wrong. I'm mindful of the sort of examples we've heard today. I did sit in a root cause analysis once where a radiological imaging process went wrong because a radiographer had accidentally bumped the image intensifier and a patient was exposed unnecessarily. The very first response of everybody in that room, the very first response was just to want to sack the radiographer. You know, this is the radiographer's problem. It's an unprofessional event. It should never have happened. Sack the radiographer. As we worked through it, it became really apparent that, in fact, there was a major design flaw with the image intensifier. You could literally walk past it and bump the on-off button. And so that was a good process. It took much longer than it should have because we didn't adopt Phelps's 2-hour rule. But it's a good example of how we jump to conclusions. And some of that is because of this bias we bring. We're problem solvers, we're solution focused. We've got a waiting room full of people. We've got demand that we can't possibly meet. Let's just solve this and move on. So I think being aware of your professional biases, which to some extent reflect our history and the context we find ourselves in, there is a lot of organisational pressure, and I absolutely acknowledge that. We've got to be better than that. What else did I say? This is another lesson for me in playing around in some of this work. It's Paul Keating, and prior to that, Jack Lang's great statement, in the race of life, you should always back self-interest because at least it's trying. And Jenny, just picking up on some of your comments as we were chatting before, I think one of the challenges in all of this sort of work is that we have got a degree of self-interest in it. That's one of the reasons why I think we should all step right back and think deeply about purpose. What are we trying to achieve in this organisation? What are we trying to achieve as professionals? Patient, 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 purpose, purpose, purpose. I think it's very easy when we're looking at a problem, when we're looking at a challenge, to try and take ourselves down the path that satisfies some other ambition rather than really getting to the root of good patient care. It's an inalienable rule of life that Paul Keating talked to there. I think this is really important. You've kind of alluded to this in your conversation. I want to start every conversation about improving in healthcare from the basis that we've actually got enough resources. I didn't talk about it in my talk, but there's ample evidence now that around about 50% of every dollar we spend in healthcare in Western democracies like Australia is not adding any value at all to the person on the receiving end of care. It's a great example you showed. The starting point there was we need more people, more resources. I have very little time for colleagues that I talk to about quality improvement who start the conversation with, we can deliver better quality care if we have more resources. That tells me an awful lot. So I do think we need to conceptualise improvement around this idea that we're going to have to work with what we've got. We've seen an awful lot of resources come into healthcare, and particularly hospitals in the last 2 years, as governments have just chucked money at hospitals. I actually think, being really big picture for a moment, that's almost the last thing we need. We need much more resources put into the community where people are, and in order to keep people out of hospitals, but let's not go there. I talked before about systems. In terms of the booking arrangement piece, let's radically rethink this. Why do we think that with our technical knowledge, and there's vast technical knowledges in places like this, that we know how to build systems that meet our people's demands? I want to see projects which are actually patient-led, where we contribute our little bit of technical knowledge into it. But they know much more about booking systems than we do. We're lousy at booking systems in healthcare, if you think about it. Most booking systems, in my experience, are actually built around our needs. You know, I've got to do a ward round in the morning, I've got to be at a private hospital, I can only start at 9 o'clock. That sort of stuff. And this is just a bit of a sidetrack, coming back to the joy at work thing, just to tap into that. I think we're dealing with a workforce now which is really fatigued. I think we acknowledge that. There's a real risk as we go down this path of change at scale, which I am absolutely committed to and completely believe in. There's a real risk that we're going to push our people too hard. And so I just think this is really important for managers and leaders in organisations to balance up the need for change, balance up the work that's required to change with a need to ensure that our staff still have joy at work. So that's a major sidetrack, but I think it's a really important thing that we're all grappling with now as we seek to improve our systems. So I'll stop.
Fantastic, thank you. Really great thoughts. I'm going to invite James, Rob, Grant to the podium here. And we will hand over to Rob in just a moment. But actually, just picking up on what Grant was just saying, is actually we can create joy at work by empowering staff to remove the pebbles in their shoes. And what we mean by that is by giving them the tools and the techniques and the time to be able to problem solve, get rid of the things that are niggling at them, that are causing them frustrations, and to really empower them to improve their systems and processes, actually will then create a change in their well-being, in their culture, and actually provide them with more joy and satisfaction at work. And we have recently heard about that at the International Healthcare Quality Forum. So, Rob, I'm going to hand over to you to provide some insights on this topic, and also to provide some reflections after the topic earlier today.
Thank you. Thanks very much for your examples. They're terrific. Look, most of you, I can look at the room and see that the majority of you have done the CIP course, so you're probably sick to death of hearing my thoughts on these matters. Just a little story about resource. So some years ago, well, for years actually, we'd had a problem in operating theatres with image intensification. So image intensification is a mobile X-ray machine that takes pictures of things in operating theatres that we need to, so bones, urology type procedures, looking for stones or the placement of catheters, or gallbladder operations, getting an image of the bile duct. And we, for years, had suffered from wasted time with people standing at the operating theatre waiting for an image intensifier to get their picture. And if you added up all the time that was wasted, it worked out that we needed another image intensifier. But if we needed another image intensifier, we actually needed another radiographer. And if you needed another radiographer, what happened if that radiographer was on holidays? So then you need another half a radio. You can see how it escalates into a huge problem. And we'd put in BCTs for another machine and a radiographer and all the other things that go with it, and they'd always been refused. Anyway, you would think that we'd sort of cottoned on a bit earlier than this, but we decided, well, why don't we actually subject this to proper problem solving find out what's causing the problem, go back to basics. And anyway, we did. And remarkably, we'd never engaged a radiographer in any of these discussions before, but we engaged the head of radiography, Chris Pilkington, and he had insights. We engaged all sorts of people with fundamental knowledge who were part of the process. Anyway, the long and the short of it is that we solved the problem, that we actually had enough resource. All we needed to do was make some changes in notification, some minor changes in scheduling, and there were a few other bits and pieces, but there was enough and it all worked. And I thought, wow, how could I fall into the trap of not, for so long not realising this, although on the other, going and putting another hat on and preaching the improvement stuff, it was sort of, oh dear. There are quite a number of projects that we see coming through the CIP program, similarly, or of similar flavour, where there's not enough of this, not enough of that, and we need more resource to make it all work. Gynecology, Bruno Radicic did a fantastic project on colposcopy, and they had determined that they needed more resource, all the usual things. In fact, they had too much resource. They just weren't organised appropriately. But it was another great example. So there are many of these sorts of things. Now, unfortunately, you can't look at a spreadsheet or look at data and understand what the problem is. And I can't emphasise that enough. You need to go look and find out what's causing it by maybe looking at other pieces or finding other data, talking to people who are actually doing the process, and, in other words, engaging the people with the fundamental knowledge. These are the frontline people. Now, they may be administrative staff, it may be allied health, it may be radiographers, it may be junior doctors, it may even be senior doctors. But the data will alert you to the fact that there may be a problem, but it won't tell you what it is. It's getting all the other background information. So that, unfortunately, we tend now to look at data and leap to conclusions and then start off on a program of trying to solve the problem. Wow, we can really go down some rabbit holes doing that. So there's a thing called the data hierarchy, data wisdom hierarchy. So data can give you information which can translate into knowledge, intelligence, and ultimately wisdom. You can get to intelligence with computers. You need the human factor to get to the wisdom part. And we really do need to subject all the information we have to translate it into knowledge, okay, ultimately, and at the end of the line, wisdom. So so I'll just digress for a moment. Grant mentioned something earlier this afternoon, and this is about looking at data and finding out where the poor performers are and focusing on the poor performers. Deming's final point was involve everyone. In other words, don't go looking to see in some piece of data where a perceived poor performer lies. Subject the whole organisation to the same process. Because just because you fall within some confidence limits or average or within 2 standard deviations, I can promise you that everything that's happening within that is not perfect by any means, and all of it can be improved, and by focusing on the whole system and the processes within the whole system, you will get far, as an organisation I'm talking about now, far better bang for the buck by involving everybody. Also, there are not perceived winners and losers then. It's not, you create this, oh, well, I'm okay, so it's all your fault. You've got to improve. It sets up a bad culture.
and it's actually super satisfying to improve. So.
And that's another thing that I heard someone say at the international meeting was, don't strive to be the best organisation, strive to be the best at improving your organisation. Now, I think that's a really important message, because what it allows us to do is compare our own performance longitudinally and see where we're going, not trying to find perpetually these external benchmarks that may or may not be relevant, and you tend to go searching for reasons as to why it's not relevant. Do you know what? Look at our own performance and track it over a long period of time, and you get a huge amount of information out of that. But it reinforces this idea that we're the best at creating improvement. The rest follows, do you know? The rest follows on from that. It's getting your own organisation and focusing on your whole system. Perhaps I'll shut up for a moment. I'll pass over to somebody else.
Did any of the other panellists have anything more they wanted to add to any of that? Grant?
And only that I agree entirely with Rob. And my premise this morning was that organisations can deliberately choose to be elite. But you're absolutely right, Rob. What in reality organisations are choosing to do is to be as good as they can be. And that individual organisational journey towards improvement is the key. Brent James teaches this idea that you should benchmark against your own excellence. And I think that's right. We use external benchmarks to guide us and data to guide us, but it's us that we should be focusing on. And again, I really like the work you're doing here, because it's very much about this organisation, its culture, and its task to be as good as it can be.
Do we have any questions from the audience for the panel? Jenny? I'll just grab a mic. Constance?
Thank you. Thanks very much. It's been a really interesting session this afternoon. But I just want to ask the wicked problem about how can we apply continuous improvement to our really wicked problem around ramping. I mean, I think I'm having an aha moment about it, about the answer. But Rob, in particular, why can't we use continuous improvement to actually fix this problem?
We can.
So why haven't we done it?
Because, okay, thank you. Because we were so solution orientated. We didn't want to spend the time trying to find out what was causing the problem. We, to some extent, assumed we knew what was causing the problem, but we didn't actually spend time talking about doing the diagnostics. Now, and so the solution was a series of sprints. I mean, really, it's just unbelievable, because we really need to spend the time trying to understand the problem before we move to the solution bit. Now, it's a multifactorial. There's no one thing.
And that's my
there's no one thing.
But from an organisational perspective, from an organisational perspective, I mean, we've got 1,000 flowers blooming with some really fantastic projects across the organisation. But how do we apply CPI at a strategic or a higher level so that we can actually have a go at fixing this problem?
So I have a solution for this, Jenny. I would like the board to enrol in the next course, which will be... So, thank you for volunteering and bringing along a team from the board. In fact, I'm actually quite serious. I was thinking about that while we were doing the last course. I think unless our thinking is aligned, and so I only say it from this perspective, that unless our thinking is aligned, in other words, at board level, at executive level, and at clinical level, we've got no chance, because we'll continually be butting heads. So we need alignment of vision and understanding, and then partnerships in developing understanding as to, yes, all those simple things. What's causing the problem? What are the possible solutions? And the ramping thing is an incredibly complex problem. But the way to deal with complexity is not, as Grant says, it's not a simple answer. It's breaking down all the component bits and then chipping away at it and designing your systems to become more efficient, to, not imposing solutions. For example, the direct admission pathway is an absolute beauty. I completely understand that ambulances are really frustrated by arriving at this organisation and then having to wait with what appears to be a simple thing. But there are many complexities associated with the direct admission thing, particularly when there's an electronic medical record at Noarlunga, which is different from the electronic, with no unique identifier, no way to pass on orders, drip orders, drug orders, whatever, clinical orders. So, suddenly underlying it all, there are all sorts of issues. But for every direct admission pathway bed we keep, there's someone in the ED that doesn't get a bed, So actually it's not a solution. That's a bit of a workaround so that particular ambulance is not, and I can understand it from the ambulance perspective. I think, it's just a horrible, horrible problem. But in terms of our system, it's not improving one thing, really. Maybe I've sown the seed now, and I'll leave it there. We can have other discussions about various bits and pieces of it. But I will say one more thing, in amongst the sprint work, these clinical improvement unit did some fantastic mapping. So they did spend time. We're extraordinarily fortunate in this organisation to have a very talented group of individuals in the clinical improvement unit whose job is doing this sort of thing, because the insights that they provide are marvellous. And, one of the best parts of my week is meeting with the improvement unit to find out what they've found out to educate me, and maybe I can help a little bit. But wow, it's such a rich environment of information and knowledge, wisdom gathering that happens. So, congratulations, Angie, and your team. You're doing a sensational job.
It's a pleasure of also myself sitting and listening to the team and the amazing work that they do. I would also, just to add on what Rob is saying, is that this perception of quick fixes or quick wins, and Rob often talks about this in his talks, is that it's actually a little bit insulting to think that if it was a quick fix or a quick win that we hadn't already thought about it already. And so I guess, and going on from the work, is that we need to trust the process, and that actually to do this properly, it does take time, but it also it takes effort and discipline to stick to the course. And so the example that I provide is that from the sprints, we've been doing a lot of work around medical imaging and some improvements around medical imaging, and actually we're only just getting to real, true understanding of the problem now, and it's been quite a few months after starting that project. And so it takes discipline to stick to the course, and then to see the project to the end. And the thing that we suffer with is that then we've already got another 12 projects we need to start. And so, do we continue on the course with the projects that we're ready to nearly get to true root cause, or do we then abandon those projects and do we start the next 12 that we've had, that are now going to be the next area of focus? And so I guess it's a matter of making sure that we're really clear around purpose, which Grant has spoken about, and are we going to stick to this course, or are we going to abandon them and then go to the next thing that we think is going to solve the true ramping process?
Yeah. I was just going to say variation. There's so much variation around, and we've got a lot of change as well, of course. And so that's one of the challenges, how to try and reduce our variation in so many ways wherever we can.
Sorry.
Not talking on anything specific because I'm involved in some of the things that are being discussed, but from what I've witnessed across many jobs in many different health services and LHNs and all the rest of it, is you're pushed, doesn't matter what level you are, you're pushed to get things done. Whether it's the quick wins reporting or whether it's a clinician who you just need to get your medication round finished and you just don't have the capacity to do this. And I guess my question to anyone who wishes to answer is that how do we, as a beast that is health, get better buy-in that this stuff should be at the front end of the focus so that the patient can be receiving the best care possible? And how, like, from the clinicians who are too tired to care through to the executives who need to show the board some results, how do we get better buy-in?
We'll turn that over to the consultant.
You have a framework. That's a good start. Every consultant has a framework. Look, I think that's the existential question here, isn't it? But underpinning it is, I think, is a couple of things. Firstly, a view that it can be better. And we know that it can be better. And this organisation's a great example of that. You're doing great work and you're improving care in a really meaningful way. And as we talked about this morning, that pushes buttons. It pushes staff's buttons. It pushes consumer buttons. It ultimately pushes an organisation's buttons. I think it's important, just to circle back to your question, Jenny, I think it's important that the top of the organisational chart really leads on this as well. And Rob, I think you're absolutely right to engage organisational leaders in an understanding of the methodology that underpins this, because that then can very quickly translate into a real willingness to strongly support this. And there's no question that whilst we have enough resources, sometimes it does need some seed funding or some seed resources or some time, and that can only come from senior management decisions. At the end of the day, you're not going to engage everybody. And some people may in fact walk away from an organisation like this if they feel that this whole process improvement thing is not where they want to be. That's that clash of personal versus organisational values. It's kind of the clash that I alluded to this morning, that we've spent a lot of time in organisations like this pretending that things are going to be better if we're just a bit cleverer. I'll teach you to be a bit smarter. That's quite at odds with the systems approach, which says we'll make our system so good that it doesn't matter how clever you are, it's going to work. And that's, I think, a real cultural clash for many of us. But equally, I think the evidence is pretty clear, and you're now, I think, at this point that once you train enough people in the methodology, they'll get the bug. And, Rob and I are good examples that once you get the bug on this stuff, it kind of infiltrates your life and never lets go. It's a bit like being an ex-smoker, I suspect. Once you get enough people with the bug, organisations will shift. And I think if you really look at this organisation carefully, you'll see evidence of real shift. And which is why I said before, just keep going, get to 15, 16, 20% trained. Unstoppable.
I should emphasise I'm not from Salem. So Grant, what's the saturation level? Do we need 50% of people trained or 80%?
So, Jenny, we talked about this morning. The evidence, such as it is, and there's not a lot to be fair, says that when you get to 7 to 10% of your staff trained and 7 to 10% trained and believing, you're pretty close. You're well on the journey. So, Rob, you've got 8%, give or take a bit?
Yeah, we think around about that, 7 to 8%.
Yeah, you, in many ways you're there, but keep going, don't stop. Back to the wicked problem, because I just want a couple of comments about that. I don't think ramping's the wicked problem. I think that's a wicked outcome of a series of wicked problems, at the core of which is that Australia's health system is structured in such a way that this is an inevitable result. All systems are perfectly designed to deliver the results they deliver. What I'm seeing around the country is, in response to the perceived wicked problem of ambulance ramping, that what we're doing is simply building bigger and bigger emergency departments. And I keep seeing hospitals that are emergency departments with a small hospital attached. It is truly bizarre. But governments can open an emergency department, cut a ribbon and feel good, and votes may follow. Our political cycle sadly does dictate that sometimes we get real short-term decisions. Political leadership in this country is really needed to address the jurisdictional problem. 9 separate jurisdictions in Australia are approaching this problem very differently. and yet we're all Australians, we're all part of the same milieu, we should have the same expectations. So I think the wicked challenge is a political one, Jenny, to bring people together and show them what's happening. Walking a bunch of politicians through the life of a frequent user of an emergency department, I think would really open some eyes.
I would just like to return. Sorry, would you? Where are you from? Right. Okay. So I just wanted to be sure before I said anything. No. It's more along the lines of how do you align the vision. And Grant mentioned this morning or this afternoon that it's what is the mission of the organisation? Well, ultimately the mission of the organisation is to develop or deliver high quality healthcare to our population, our patient population, the ones coming through our doors as it stands at the moment. Now, if you couch everything in those terms and then start thinking about joy at work, well, what's the point of joy at work? Well, the thing is, if you've got a happy workforce who want to be there, they will do a much better job and the patient outcomes will be better, so you can tie it all together. Similarly, why do we have governance systems? Well, governance systems should be about producing patient outcomes, not about controlling people. It's sort of... Now, I saw a perfect example this morning where we were talking about a strategy for a just culture. And the rationale was there are all these legislative requirements, and so we need to meet these legislative requirements. Oh, well, how motivating is that? It's sort of, wow, it becomes a... But if we relate it to what's the mission of our organisation, and if we do manage to achieve a just culture, the likelihood is that people will get more joy at work, they will be able to do a better job, patient outcomes improve. So we should be making it aspirational to provide the best environment we can for the people to do the best job they can. And a lot of the tiredness, burnout and all that sort of thing is attributable to making it hard for people to do their job. Take away the pebbles, I think, as Angie said, or start to chip away at taking away the pebbles, making it easier for people to do their job, creating the joy at work, creating the just culture, better patient outcomes. I mean, it all joins together, and I think that's the vision we need to promote, not the one, we've got to comply with this, we've got to comply with that. Yes, there has to be a baseline, of course. And yes, we have to achieve that, but that's the minimum standard. That's not our aspirational goal. It is possible to get carried away with this stuff, and and I'm very guilty of it. But when you start doing brainstorming and Pareto charts at home for your children, then you start to hit brick walls.
Amen, brother. Yeah, I was just going to say that. Yeah, I really think that people working with the patients can see what drives them nuts. And actually, when you start to use these improvement tools, you can actually do something about some of those things that drive you nuts. And as you say, that leads to joy, I think, and the idea that absolutely it's possible to aim for a better, brighter future together. But of course, there's the high-level government components that are drivers as well.
Sorry, Andrew.
No. So can I want to just change direction a little bit and just maybe get into a philosophical bit about this. And I'll state the question and then sort of go on from there. In embedding this and making this have longevity, if you've done something like feeding the ducks a bit earlier, does everybody have to understand why you do that? Or is that just what we do? Is that part of our culture? That's what we do in our place. And I'm going to give you an example of that. So if you're in discovery science, you want to understand why things happen. If you're a clinical trialist, you don't give a damn how things happen. That's not important at all. It's just whether it happens or not. And they're quite opposing sort of views in all of that. I'm just interested in the thoughts because I get it that you create a culture, that's how we do things, but I'm nervous that in 3 years' time, somebody else will come along and we'll get somebody else who's now looking after the feeding of the ducks. And I'll say, well, I know that's what they did then, but I don't know why they did that. And I think what we'll do is do it like that. So where's the balance in that?
Andrew, it's a great question. I think organisations create culture largely from the top down, and in public hospitals like this, some of that culture derives from major political decisions. But the keepers of culture in an organisation like this are not at the top of the organisational chart. That changes pretty frequently. The lifespan of a CEO of a hospital in Australia is 3 years. Jenny, that's about right, isn't it? Seriously, the keepers of culture in places like this are you. It's the people who work at the clinical coalface who are here for decades. And the thing that excites me about the work you're doing is that you've now been doing it for 20 years and you're at that tipping point where you know if you keep going, you're going to have sufficient numbers of your staff deeply engaged with this. You can change the top of the organisational chart as often as you like, that culture will remain. Now, within that, there are complexities. Health's a complex business, Andrew, and there are always competing priorities. But the overarching purpose of focusing on patients, focusing on continuous improvement in their care won't go away. I've got a high level of confidence about this organisation that I don't have about many other Australian hospitals because of the time you've been doing it and the fact that it is now embedded in your culture.
Do you want to add to that, Rob?
Oh.
I mean, ducks are super cute, Andrew.
Yeah, I really agree with Grant that. So we'd been doing the improvement stuff for a while, but it wasn't really until Sue O'Neill came along and said, actually, this is how we're going to do it within the whole organisation. So Sue was an enabler to enable that to spread throughout the whole organisation, and I think, that hopefully that will be an everlasting legacy. But to make it survive, it needs that all the clinical divisions and units and people to be aligned with the vision. Not everyone needs to have the understanding, but the more people that do, the better. So yes, there is an educational component to it, but there's a doing bit, and I think when it reaches the point of this is how we do business, and we're pretty close. We're pretty close. So I'm very heartened that once a few of us leave the organisation, this will just continue on because it is now part of the DNA.
And can I just add to that, actually? We are now even starting to see medical staff become part of the faculty, and I think that is really exciting, that it's not only just seen as a nursing or an allied health, that we are starting to reach medical staff wanting to be part of the faculty and coach their colleagues and their around this is how we do improvement, and they're so signed up to it that they're willing to put their hand up and say, I want to be a faculty member. And I think that is really, really exciting as well.
There's one sitting here.
Yeah, Nadia. Yep, Nadia's coming on board, which is fantastic. I think we've got time for one more question. Have we got any other last questions of the audience? No? I think it's been a really great session. I just want to thank Grant, Rob and Jane for their insights and their wisdom. And step by step we'll continue to grow. And I think it's been really heartening to hear the reflections from Grant about how great and well-placed Sarlan is, and it really does provide a great foundation for progressing forward as we continue on. So thank you to everyone for attending.